We have 5 judges, but unfortunately we are having 2 judges. So presenters, you will be, it's for you people to be easy. So you will be evaluated by the 2 people only. So it's my honor to invite Dr. Salma Hemero Madam. Kindly come onto the stage for the judging the session. Have a big round of applause for ma'am. Next on the line, I would like to invite Dr. Padmavati Maji ma'am. Kindly come onto the stage. Thaya bo baban bonda, thaya to baban range jo apale. हाँ. So it's a very tricky scene for you people. Another judges have joined. I would like to invite Dr. Durgi Saran ma'am. Kindly come onto the dais on the stage. Madam, Avinda no basta.
Hi, na bata. Pero chair to adi gan mena thalya. Hol ke le komo.
Judges are requested to go with the score sheet. Pen man. So I would like to request some volunteer for the timekeeping. कोई भी आ जाओ भाई आगे. हाँ, you are there. Okay. So due to flexibility of the time, we are giving 6-minute presentation and 2 minutes for question and answer session.
8 minutes total.
So total we have 8 minutes. Because we have less presenters, we expected 24 numbers of participants, but unfortunately we are having only 8 presenters. So we will utilize the time judiciously. And again I am repeating, 6 minutes for presentation. Judges kindly note, 6 minutes for presentation and 2 minutes for question and answer session. And judges, you are very right to stop the presentation whenever you want.
Yeah.
So moving with the first presenter, Dr. Dhananjay Murmu.
Third year.
So now over to judges.
6 plus 2 bhai. Huh?
So judges, can he start? हाँ.
जतो को के जोहार नितो सेटर कन सनम को के सगुन दाराम और सगुन सेता न्यानु तुम दो धनंजय मुर्मू इन द थर्ड ईयर एमबीबीएस स्टूडेंट कने धरणीधर मेडिकल कॉलेज एंड हॉस्पिटल केउंझर. So today I will be presenting on the topic neonatal sepsis. Before a deep dive into the topic, here is the quick overview and the overview of the contents that are present in this presentation. It includes basic overview, major causative pathogens, classification, risk factors, clinical manifestations, diagnosis, treatment, prevalence rate and comparison across regions, epidemiological state data, and conclusions. Yes. So the first question comes, what is neonatal sepsis? Neonatal sepsis is a bloodstream infection that occurs in the first 28 days of life. It is one of the leading causes of morbidity and mortality in infants among both developed and developing countries like India. It is most commonly caused by bacteria. The major causative pathogen includes gram-negative bacteria like Acinetobacter, E. coli, Klebsiella, gram-positive bacteria like Staphylococcus aureus, fungal pathogens like Candida. When these pathogenic organisms enter into the circulation, it causes infection and cause neonatal sepsis. Based on the distribution in the body, it can be classified into generalized and localized. Generalized neonatal sepsis like septicemia, and localized sepsis like pneumonia localized to lungs, meningitis localized to meninges, and osteomyelitis and arthritis localized to bones and joints. Based on the onset, it can be classified into early neonatal sepsis and late neonatal sepsis. Early neonatal sepsis occurs within 72 hours of birth. The major cause of early neonatal sepsis is maternal infection, whereas the late neonatal sepsis occurs after 72 hours. The major cause of late neonatal sepsis is environmental infection. So the major risk factors can be categorized into maternal factor, fetal factor, and environmental factor. Maternal factors like prolonged rupture of membranes, UTI infections, maternal group B streptococcus colonization, and multiple pervaginal examination. Fetal factors like prematurity, low birth weight, and inability to breastfeed. Environmental factors like unsanitary handling of baby and unsanitary caring of an umbilical cord. Frequent blood sampling and intravenous line insertion. Prolonged hospital stays also affect the neonates. So now let's look into the clinical manifestation. The clinical manifestations or clinical features often are non-specific. The general manifestation that we can find in a neonatal sepsis baby is poor feeding, lethargy, irritability, poor weight gain, fever or hypothermia, tachycardia, respiratory distress, abdominal distensions, vomiting, feeding, seizures, and skin manifestations like petechia, cellulitis, jaundice, and purpura. So here is a quick pictorial representation of the manifestations that we can see. Now moving on to the diagnosis part, how we can identify and diagnose the baby coming to the clinic. So first, there is a screening. First we have to go through the screening process, for which we have neonatal sepsis screen. For confirmatory purpose, we have blood culture, which is considered as gold standard, and additional investigations like CSF study and lumbar puncture for in case of meningitis. For we conduct chest X-ray for pneumonia, blood glucose monitoring for hypoglycemia baby, or blood glucose monitoring for any respiratory distress present in the baby. So, what is neonatal sepsis screen? So, as we have learned that for screening purpose we use neonatal sepsis screen. It consists of various parameters like TLC count, absolute neutrophil count, immature neutrophil and total neutrophil ratio, C-reactive protein, and ESR, erythrocyte sedimentation rate. So if any of the abnormal conditions identified in this in these parameters, then we do. Yes, ma'am. So the basic clinical tip is, if 2 or more parameters are abnormal, then we have to start the empirical antibiotic with collecting the cultures. So coming to the treatment part, the non-drug treatment includes hand washing, keeping the baby warm, breastfeeding the baby. The drug treatment includes ampicillin, cloxacillin, gentamicin, cofatoxamine, and amikacin. So now looking at the prevalence rate and comparison across the various regions of India, the prevalence rate worldwide average is 25. In developed countries, it's 3. In developing countries like India, it's 30. Basically, in India, it's 28. Moving on to the incidence rate, in India, it's 30 out of 1,000 live births. In Odisha, in rural areas, it's 6.7. So to tackle the cases of neonatal sepsis, our government of Odisha has taken various steps like infrastructure like SNCUs, home-based neonatal cares, Janani Suraksha Karyakram schemes, Mamta schemes, Lakshay scheme, Rashtriya Bal Suraksha Karyakram, and Nirmaya schemes to improve the morbidity and mortality of neonatal deaths.
Your time is over, huh?
This is last.
Last. You can.
So, at the end, neonatal sepsis remains a major public health challenge, particularly in low and middle income regions like Odisha and across India. Early diagnosis, timely treatment, and preventive strategies are crucial in saving newborn lives. Strengthening health systems, community awareness, and government programs like SNCUs and JSSK are essential for long-term impacts. At the end, every newborn deserves a chance to survive and thrive. Preventing sepsis is not just a medical duty, it's a moral one. And here are the reference I have used for this PPT. Thank you, ma'am.
Audience Sarha, Dhananjay Babu. Any question from the audience?
Regarding reference, when you're going for presentation of the reference, now you don't just put .google.com, okay? There is a way of presenting your reference. Your presentation is very good, but since you people are still learning, I'm advising you for reference, better to look for how to refer your presentation. I am not going to, tell you currently, but I will suggest all of you to at least Google it, how to refer or cite articles, okay? There is a very good method for all of you, active learning. Me telling you is not going to help you. This is going to be an active learning for all of you, how to refer when you are going for presentation, okay? Regarding the questions, everything is okay. Have you people, yes, Dhananjay. Have you yourself seen any neonatal sepsis in your college when you are going for, not yet. So it has been taught to you in theory only. Okay.
In second year, we have gone for pediatric clinical postings. That there we have seen one case only. It's I am still in third year, so pediatrics class is not started.
So okay, from
so my comment is only for the reference part. Since you people are still learning, I'm not going to comment a lot of other
Yes, ma'am.
things.
Thank you, ma'am.
Audience can ask you, but there is a method of referring. Okay.
Yes, ma'am.
And you don't just put Google. There is a way of when again if you are accessing something from the internet, you have to again write. You access from this particular site on this date. That
Yes, ma'am.
needs
I
to
have
be
mentioned the STG Odisha.
yeah, but according to date. When you are referring a government site, you can directly refer that you have referred from that. But when you are coming,
Internet.
and again, on which date you accessed, you have to write that.
Yes,
Okay,
ma'am.
from this site, access on this.
Yes,
And you don't just put Google.
Yes.
Okay,
Thank you, ma'am.
thank you.
Dhananjay Babu, very nice presentation.
Thank you,
And
sir.
one question from my side: what are the possible consequences or outcome of this new?
Judges are given permission, sir, I think.
No, Mark in the tabulation, audience questions are also there, sir.
If you can take question.
So okay.
Please, sir.
So should I ask the questions or it is?
One question.
Audience
is
can
allowed as per
ask the
judges.
question.
So Dhananjay Babu, very nice presentation. One question from my side. What we would like to ask you: what are the possible outcomes or consequences of neonatal sepsis? 1, 2.
Sir, in the extreme case, it may be mortality, death
That
of
is the ultimate.
the ultimate.
Then before that, if
Before
something
death, we
happens-
can have various diseases like jaundice, respiratory distress.
One is jaundice. Okay, second is,
respiratory distress.
then third is multi-organ failure. That is then leading to death. Okay, that's it.
Thank you, sir.
Thank you. Thank you. Dhananjay.
No question from audience.
Shruti Murmu. Over to you, judges.
Good morning, everyone. Myself, Shruti Murmu. Before I begin with definitions and pathology, let me start with a story. A person starts drinking socially, a drink to celebrate, a drink to relax. Over the years, this habit becomes a routine. Inside the body, the liver silently metabolizes alcohol. At first, it adapts, then it accumulates fat, develops inflammation, and gradually scars. What begins as a reversible change may end in an irreversible cirrhosis. This silent, progressive spectrum of liver injury caused by chronic alcohol consumption is known as alcohol liver disease. So the contents of my presentation include epidemiology, etiopathogenesis, clinical features, diagnosis, complications, and management. So we all know that alcohol is the leading cause of chronic liver disease worldwide. And the WHO data shows that 30 to 40% of the adults consumes alcohol daily. And alcohol liver disease contributes to nearly 19 to 23% of alcohol-related deaths, making it the eighth highest risk factor for death. So I moved to the etiopathogenesis. Alcohol does not attack the liver in one day. It wages a slow war, and the outcome depends on how much, how long, and who is drinking. First and the most important factor is the quantity and the duration of alcohol intake. The risk of alcohol liver disease increases as both the amount and the duration of alcohol consumption increases. Chronic heavy drinking is the strongest determinant. Women are more susceptible to alcohol liver disease due to their lower gastric alcohol dehydrogenase activity and the higher body fat. So women develop ALD earlier than the men. Genetics also play an important role. Genetic polymerization affect alcohol detoxification pathways. ALDH2 deficiency leads to acetaldehyde accumulation, which results in flushing, nausea, palpitation, and liver toxicity. Homozygous individuals have almost no enzyme activity, leading to alcohol intolerance, which indirectly protects them from heavy drinking but increase acute. Alcohol acts as a direct hepatotoxin and initiates an inflammatory cascade that produces a spectrum of liver injury. It metabolizes acetaldehyde and causes which causes oxidative stress and mitochondrial dysfunction, lipid peroxidation, and activation of inflammatory pathways. Liver injury is both toxic and inflammatory. Inflammatory cascade. Alcohol ingestion triggers cytokine release like TNF-alpha and activates Kupffer cells and causes metabolic dehydrogenase, leading to progressive liver damage. So these are the spectrum of ALD. So what are the red flags of the failing liver? Alcoholic fatty liver. It is asymptomatic, hepatomegaly, right upper quadrant discomfort, anoxia, nausea, fatigue, reversible with abstinence. Alcoholic hepatitis. Weight loss, nausea, vomiting, fever, jaundice, tender hepatomegaly, right upper quadrant pain, and ascites. Alcoholic cirrhosis. Weight loss, fatigue, muscle wasting, jaundice, splenomegaly, peripheral edema, portal hypertension, esophageal varices, spider angioma. palmar edema. So what are the diagnoses? First,
1 minute more.
clinical history. Second, laboratory findings, AST, ALT, GGT, and MCV, serum bilirubin, and imaging ultrasound, liver biopsy is the golden standard. From fatty to fibrotic, a visual journey. Here we can see from a healthy liver, it changes to stenosis and then steatohepatitis and liver cirrhosis. Hepatic steatosis. It begins as a small droplets that collapse into the large droplets which distend the hepatocytes and push the nucleus aside. Stagnant ring cells appearance. Stagnant ring cells are nothing. They are the damaged filament within the hepatocytes. So there are the two types of steatosis, microvascular and macrovascular. Microvascular, early ALD, and macrovascular, late ALD.
Your time is over, Shruti.
Okay. Alcoholic hepatitis. Here we can see ballooning degeneration and mammillary dengue bodies, inflammation and necrosis, and infiltration by neutrophils. Then alcoholic steatofibrosis. Here we can see sinusoidal stellate cells, chicken wire Fennan's pattern, and damaged fibrosis and Linic cirrhosis. How the body pays the bill for everything. What are the complications? Here we can see the complications. Hepatic coma, massive
You can stop,
gastrointestinal hemorrhage, intercurrent infection, hepatorenal syndrome, hepatocellular carcinoma. What are the management? So for alcoholic steatosis, absolute alcohol abstinence, nutritional therapy, management, alcoholic fatty liver with support reversible within weeks. And for alcoholic hepatitis, we have to assess the MELD score, which should be less than 20, and corticosteroids, prednisol, and acetylcysteine.
Shruti, time is over. Okay.
Okay, you will be getting more time, don't worry. So in this forum, thank you for this time.
Thank you.
A timekeeper is there, sir, timekeeper is there. Chairpersons, you can have question or you can ask of audience. One or two questions. Exactly.
See, Shruti, your presentation is okay, but I think the time limit was already mentioned in the brochure, isn't it? So
Yes,
henceforth, prepare accordingly. There are a lot of contents which can be present in a short version also. So prepare in advance accordingly. Okay?
You can take one questions from, because there is a mark in question and answer, so you can take one or two questions. Chairpersons, you can take one or two questions.
Audience, any questions?
Yes.
Huh.
Yeah, what is the normal permissible alcohol drinking amount? Is there any answer?
You can
Abhinda,
don't worry,
you
you
What
will
should be
read.
the
You have so much of time, you will
blood
read.
limit for alcohol
Yes.
for driving?
It is according to the guideline. Actually,
Yes, according to the guidelines.
Pardon, ma'am?
agreed guideline.
What should be the maximum blood limit of alcohol for driving, which is allowable for driving? Beyond that, of course.
Ma'am, I have no idea.
Sir,
Okay,
sir,
learn
she
then.
has no idea. She
And
will
is
read,
there
she
any
will- she will
difference
read.
between alcohol and heavy alcohol drinking?
Sir, again,
Alcohol
she will read,
drinking,
sir.
heavy
She will read and
Acha.
Okay.
Thank you.
thank you, Shruti. Thank you. Now, I will like to request Padmavati Hansda from
ଆଜ୍ଞା।
So this is the pointer. You can, if you want to use the pointer, right up. This is the pointer. You have to toggle it. it select channel.
ଆଜ୍ଞା।
रुको. Timekeeper, we ready? Yes, you can start. Yes.
A very pleasant morning to one and all present over here. Respected judges, I am Padmavati Hasda, a third year MBBS student of DDMCH Keonjhar, going to represent the topic Preventive Measures of HIV Infection. First of all, what is HIV? HIV is the human immunodeficiency virus. It is a virus that compromises the immune system by invading the T cell and multiplies once it gets inside of it. The newly manufactured virus beats from the T cell, eventually destroying the host cell till there are low number of T cell and high viral load. Now, what is AIDS? AIDS stands for the acquired immunodeficiency syndrome. It is a set of symptoms and infections resulting from the damage to the immune system caused by the HIV. This condition reduces the effectiveness of the immune system and leaves the individual susceptible to the opportunistic infection and tumors. The prevalence of HIV and AIDS in India. The National AIDS Control Organization has estimated that 3.14 million people lived with HIV/AIDS in India in 2023. India has become the country with third largest population of people with HIV/AIDS, the main factor being the labor migration and low literacy rate, resulting in lack of awareness and in gender disparities. So HIV is transmitted by the use of non-sterile syringe and tools, pregnancy, breastfeeding, blood transfusion, organ transplantation, and unprotected sex. But it is not transmitted by the food, drink, utensils, insect bites, physical contact, clothes, towels, toilets, and showers. So the common symptoms of HIV are flu-like symptoms such as fever, fatigue, headache, sore throat. Night sweats may occur, painful sores and ulcers in the mouth are seen, rashes may occur, swollen lymph nodes, and yeast infections are there. So the stages, there are 3 stages, and stage 1 includes the acute symptoms like headache, fever, sore throat, rashes, joint pain, diarrhea, and night sweats. The stage 2 include the clinical latency period. There is persistent swelling of lymph node, but there are no specific signs and symptoms, but the body remains infected with the virus. And the stage 3 include the severe symptoms such as blood and distorted vision, cough and shortness of breath, persistent white spots in the tongue or mouth, high fever, chronic diarrhea, and unexplained fatigue and weight loss. So now the prevention. The ways to prevent HIV are to use protection for safe sex, use sterilized needles and never share them with others, choose your partner wisely, take the medication that can protect you from HIV exposure such as pre-exposure prophylaxis and post-exposure prophylaxis. Check for HIV and other STDs on a routine basis or whenever at risk. So there are 3 types of prevention: primary, secondary, and tertiary. Primary prevention refers to the activity focused on preventing uninfected people from being infected. And the secondary prevention aims at enabling people with HIV to stay well by testing to allow to know their status, welfare rights advice, and lifestyle behavior modification. And the tertiary prevention refers to the prophylactic use of drugs and complementary therapies to minimize the effect of ill health. So there are 2 types of prophylaxis: pre-exposure prophylaxis and post-exposure prophylaxis. Pre-exposure prophylaxis is given to the people who do not have HIV but may be exposed in the future, and the medication includes the fixed dose combination of tenofovir and emtricitabine, and it is given daily every day. And the post-exposure prophylaxis is given to the people who may have been exposed to the HIV in the last 72 hours, and it is given as soon as possible, and the medication is the TLD regimen, and it is given daily for 28 days. So the treatment given is the highly active antiviral therapy with at least the combination of 3 to 4 drugs, and like example, zidovudine, efavirenz, enfuvirtide, and maraviro. So when to start antiretroviral therapy in people living with HIV? It is given, it is initiated if the CD4 cell count is less than 500 cells per mm cube, and it is a priority treatment for those individuals who are at the severe stage, or the CD4 cell count is even less than 350 cells per mm cube. And regardless of WHO clinical stage and CD4 count, it is given to all the patients, including with those with active TB disease or other opportunistic infection, HBV co-infection with severe chronic liver disease, pregnant and breastfeeding women with HIV, HIV positive individual in a serodiscordant partnership, and infants. So the National AIDS Control Program. It is the program that was implemented by the National AIDS Control Organization and was launched in 1992. The aim of the program is to prevent and control HIV and AIDS, evolving from awareness to integrated prevention.
1 minute more.
Yes. Prevention, testing and treatment, focusing on targeted intervention, blood safety and universal access to care, aiming to end AIDS as a public health threat by 2030. So prevention is better than cure, especially when something has no cure. With this, I would like to conclude. Thank you.
So CS on time, huh? Good. This is a good quality.
Thank you, Padmavati, for your presentation. Questions?
There is no question from the speaker chairpersons. So from the audience. Mike, please.
Or children.
The question is, what is the mode of
Am
transmission?
I audible? So, what is the mode of transmission from mother to baby? So, how different mother transmits to the baby?
Sir, it can be transmitted when the mother is in the pregnancy through the transplacental route, and during the breastfeeding time also it can be transmitted.
So, whether you allow the breastfeeding or not? Suppose mother is having the HIV, can you allow mother to breastfeed his baby or not?
Yes.
That is contraindication or indicator? Or that
question.
allow or not to allow?
If you no say, otherwise you will be read. You have so much of time, you will read. Don't worry. Question is, sorry sir, I will elaborate the question. Sir, she couldn't got the question, sir. Sir was asking whether the breastfeeding in HIV and AIDS is contraindicated or not. You will allow breastfeeding or not?
No.
Okay.
Another question.
Second question.
Whether the urine saliva does the contains virus or not?
Sir, it is present, but in a very minute amount, so it doesn't get transmitted through this kind of fluids.
What is the minimum viral load? Minimum viral load make it infected. What is the minimum viral load?
Question is not audible, sir. Mic is not on. Sir, the question is, sir, I can. What is the minimum viral load? Sir, for.
Hello. ठीक है तो अहीं सब इनका ठीक है अभी में सब इनका बाहर अच्छे लगा.
So again you can say, sir, I will read and I will tell you later on.
ओने आए मेंते. बात ठीक है. अरे इन्ना कौन ठीक है?
Okay. Thank you.
Thank you, Prabhu.
Madan, do one thing. Actually, you can take the two questions from audience. In any question more than that too, just for a discussion, let them know what are the questions can be asked, possible questions. But you may omit that questions, but allow them to ask so that at least we will learn what are the questions.
Okay, sir. Okay.
Okay, go ahead.
Harshita Soren.
Okay.
Yes, sir. Yes. Yes, sir. As
Thank you, sir. Thank you.
As you are
Very
living in
nice,
this low and medium quality, the breastfeeding is not at all contraindicated. Next presenter is Harshita. Harshita Soren, please come onto the dais. This is the pointer. You can use the pointer. This is Start.
Who likes a bowl of fruits over packet of chips, and who even likes 2-minute walk over Netflix and chill? Well, today we all have gathered here to discuss about a very important issue, the issue being NAFLD, a silent epidemic. Now, what is NAFLD? NAFLD stands for non-alcoholic fatty liver disease. You might be thinking, what exactly is non-alcoholic fatty liver disease? Well, it is also called as MASLD, that is metabolic dysfunction associated steatotic liver disease. Well, it is the accumulation of fat in hepatocytes in individuals who consume little to no alcohol. Point to be noted, little to no alcohol. It means even if you're not consuming alcohol, you might be having this disease. This disease is silently progressing nowadays in not just older population, but also seen in young generation. If we see, about 38% of adults and 35% of children are affected by it in India. Now, what are the risk factors for it? If we see, obesity being the major contributing factor, high blood pressure, high cholesterol, metabolic syndrome, type 2 diabetes, and family history of NAFLD. Also, hypothyroidism and polycystic ovary syndrome can be some of the contributing factors. Now let's dive into how these factors are actually creating NAFLD. First, if we see obesity, mainly central obesity, that is also called visceral fat, that is the fat that builds around your organs. Here, we can see that it increases the insulin resistance, due to which there is increased lipolysis, due to which what happens? There is free fatty acid in your blood increases, due to which what happens is that it promotes and it accumulates fat inside your liver, which promotes steatosis. Next, we can have high BP. The high BP is what causes endothelial dysfunction. Now, when your endothelial dysfunction occurs, it decreases blood flow to the liver. This leads to inflammation and fibrosis. Also, high cholesterol promotes steatosis. Then metabolic syndrome, what it does? Same, that is, it increases insulin resistance. This increased insulin resistance causes increased lipolysis, which leads to increased free fatty acid in your bloodstreams, promoting steatosis. Also, if your family already have this type of disease, there is a chance that you can definitely get this disease, as there is a genetic predisposition, that is PNPLA3 gene variant, which is strongly associated to NAFLD. Also, TM6SF2 gene is there, GCKR gene also present. Type 2 diabetes with fasting glucose more than 100 milligram per deciliter is what it also does is that there is increased insulin resistance. This causes increased lipolysis, thereby promoting steatosis. And other factors like hypothyroidism and polycystic ovary syndrome is also there. Now, how this disease, you might be having this disease, but you might not be knowing. First, we need to know about the pathophysiology of NAFLD. What happens is that this is a very normal looking liver to the leftmost side. However, if you have a very sedentary lifestyle, you are not exercising at all, you are having a bad diet, at the same time you are eating a lot of processed food, high oily food, fatty food, what happens is that slowly it progresses to steatosis. Steatosis, as we can see, is a stage about more than 5% of hepatocytes are filled, more than 5% of hepatocytes are filled with fat globules, with the nucleus being pushed to the periphery. You can see to the leftmost side in the, you can see here, is that there is fat globules, hepatocytes are filled. Now, the best part about this stage is that it is reversible. Even if you have, you can rectify it by changing your diet, by exercising regularly, by eating Mediterranean diet, and at the same time having good sleep. Now, if you are not doing that, it will slowly progress and change to something called NASH, that is non-alcoholic steatohepatitis. It is an inflammation stage. What happens is that here we can see there is formation of Mallory-Denk bodies. Hepatocyte ballooning can be seen. Lobular inflammation can be seen. And it will then progress to something called as fibrosis, which is scarring, and cirrhosis. This is the end stage. We cannot do anything about it. Now, moving on to NAFLD being a silent epidemic. It's called so because it is asymptomatic. Even if you have this disease, people will not feel sick. They will feel healthy. However, their body and their liver is unhealthy. It is getting filled with fat, as you will not have any kind of symptoms. Now, it is always good to consult a doctor. So, for lab diagnosis, first you have to do LFT. Then there are many options like LFT, liver, biopsy, imaging, fibroscan. At the end, I would like to just say that NAFLD is a preventable disease, and we have to take step. We have to make change, and as we can see, nothing is impossible. The word itself says, I am possible. So thank you.
Thank you, Harshita, for your nice presentation.
Go to the front.
Yes, ma'am.
Front.
Please show your slide, histology slide.
Yes.
Pathologists are more about.
What is that picture? What is the first one? Normal architect of hepatocyte. That
Yes, ma'am.
That one is. That is normal.
Ma'am, actually, I was referring to the upper that liver.
No, histology picture. You show.
It is not normal, ma'am.
Okay. What is that?
Ma'am, it is steatosis has been occurred. We can see that more than 5% of hepatocyte has been affected, and they have been filled with the fat globules, and nucleus has been pushed to the periphery.
Okay.
Yes, sir.
Okay. You have to show now that normal histology picture of that hepatocyte.
Oh yes,
architecture.
I didn't
Then
add,
only
ma'am.
you can describe what is the abnormal.
Comparison.
Okay?
Yes,
Okay.
ma'am. Thank you.
Questions from the audience?
Very well presented, well in
Yes,
time. Have you heard of PIP for score?
Yes, sir.
What is PIP for score?
Fit for score.
PIP for FIB PIP for fibroscore. PIP for score.
Fit for fibroscan. Fibroscan illustrator. That
It consists of PIP for score. Okay.
Yes, sir.
Clinically, you can detect what is the stage of the mass also. Eh?
Yes.
Consists of age, then total platelet count,
Yes.
and SGPT and SGOT. That is PIP for
Yes.
FIB PIP for fibrosis score for.
Fib 4.
Yeah.
Yes. Okay, sir. Thank you. Yes, sir.
What is Mediterranean food? I want to eat. I am obese.
Yes, sir. Sir, you have to eat fruits and vegetables rich in green leafy vegetables like spinach and broccoli and egg. Means like nowadays what is happening that people are eating very junk food, that street food. You have to avoid that. You have to go green and you have to eat fruits like apple, banana, all this. Yes, sir.
Thank you.
Yes, sir.
Very beautiful question, Mediterranean diet. So we'll delve deep into it later on, sir, due to lack of time.
Yes, thank you, sir.
Thank you very much, Harshita.
Thank you. Now on the line, Himani Maji. So I am requesting again, kindly stick to the time, because time is money, time is everything, and we are lacking time. अच्छा सर ओके गड़ीबन दो का OD 02 BM 8747 काइंडली वन साइड मा ओके गड़ी का ना हाँ ओंडे कौन साहे मा सर start.
Good morning, everyone. So I'll be presenting this topic, PCOS, a modern health epidemic in young women, emphasizing mainly on epidemiology and preventive perspective. Polycystic ovarian syndrome, commonly known as PCOS, is the most common endocrine disorder in the women of reproductive age. It is characterized by increased androgen production and ovulatory dysfunction, and is one of the major causes of menstrual irregularity, infertility, and metabolic disorder. It was first described by Steen and Leventhal in the year of 1935 as a triad of amenorrhea, obesity, and hirsutism, and it is also known as Steen-Leventhal syndrome. So why PCOS is a public health concern? PCOS, as I said earlier, it is the most common endocrine disorder, and its prevalence is steadily increasing among young adults and adolescents. If it is left untreated, it may lead to long-term reproductive complications, which we will discuss later. It begins early in life and progresses very silently. So early identification and lifestyle-based modification can significantly reduce its long-term disease burden. Hence, PCOS has emerged as an important public health concern and not just a gynecological problem. The prevalence of PCOS varies based on the diagnostic criteria used. However, it is estimated to affect 5 to 10% of women of reproductive age group. Polycystic ovarian morphology on ultrasonography is seen in 20 to 30% of the women, even in the absence of clinical PCOS. Presented in 70 to 80% of women with PCOS suffer from menstrual disorder, and it accounts for 40 to 50% of anovulatory fertility. There is also an increased risk of recurrent miscarriages. So the exact cause of PCOS is not known. Still, the contributing factors include genetic predisposition. In addition to that, excess androgen and excess insulin also disrupt the normal ovulation. Coming to pathophysiology, we will proceed from cause to effect and effect to clinical features. So this is a very nice diagram. So the central cause of PCOS is insulin resistance in skeletal muscle and adipose tissue. To compensate, pancreas secrete excess of insulin, causing hyperinsulinemia. High insulin directly acts on the ovary and liver. So in ovary, it stimulates the ovarian theca cells, from which excess of androgen is released. And there is also a decrease in the sex hormone binding globulin production from the liver. At the same time, there is hypothalamic pituitary ovarian axis abnormality, which cause a raise in LH is to FSH ratio. Raised LH increase the androgen production again, while relatively low FSH prevents normal follicular maturation, leading to follicular arrest and chronic anovulation. So let's see how the effect presented as clinical features. Hyperandrogenism, clinically presented hirsutism, acne, and acanthosis nigricans. Follicular arrest cause polycystic ovaries due to the accumulation of the immature follicles and also cause infertility. Chronic anovulation results in irregular cycles. Unopposed estrogen may increase the risk of endometrial hyperplasia, and insulin resistance presents as obesity and metabolic syndrome. So investigation in PCOS, starting with sonography. Transvaginal ultrasonography is preferred. We can see the pathology of ovary. It shows enlarged ovary with an increased volume more than 10 cubic centimeter, multiple follicles measuring 2 to 9 millimeter, with an peripheral follicular arrangement. It also shows string of pearl appearance as the follicles are arranged peripherally within the ovary. There is a raised hormonal we can see the hormonal
One minute left.
So the hormonal disturbances we can see on laparoscopy. We can see enlarged ovary. So the diagnostic criteria is according to the Rotterdam Consensus 2003, in which the presence of 2 out of 3 following criteria is sufficient to diagnose oligoevolution, hyperandrogenism, and polycystic ovary on ultrasonography. Coming to prevention, primary prevention. Primary prevention of PCOS focuses on health promotion and specific protection, and the government programs like Rashtriya Kishore Swasthya Karyakram, weekly iron and folic acid supplementation are the platform where awareness about menstrual health, obesity, and PCOS can be imparted. So PCOS Awareness Association is a non-profitable organization spreading awareness regarding the complications of PCOS. It is observed in the September month. So the lifestyle modification is the first line management, and the medical management when the woman doesn't require pregnancy, doesn't desire pregnancy, called combined oral contraceptive pill and anti-androgens.
Time is over, Himani.
You can, Himani, you can stop, huh?
Thank you, ma'am.
Any comments or question from the speakers first? The chairpersons or to the judges?
Yes, you said that PCOS is mostly lifestyle dependent. If someone has been having a very healthy lifestyle, so even then, can it occur or not?
Yes. Yes, ma'am, it may occur because there is always the thing is hormonal factor and genetic factor is also there, which is already present in the body. If that is present, it may also occur.
Yeah, it may be present. Okay, you cannot blame lifestyle only, but you can advise once you diagnose someone as having PCOS, then you can advise them for altering their lifestyle.
Yes, ma'am.
Okay.
Question from audience?
Is there any difference between PCOD and PCOS?
Sir, the PCOS syndrome, it is a group of several.
Required to start menstruation or ovulation?
Sorry, sir.
Already you have mentioned there. That's why I'm asking.
How much
weight reduction is required to start again ovulation or menstruation?
Sir's question is how much weight is to be reduced? Yes, sir.
Yes.
Wait.
Already it is there in the slide.
5 to 10%.
Yes, that is that is the thing. You need to record your
Only
weight
5 to
reduction
10%.
at least 5%. Then the lady will start ovulation or menstruation. Good.
Yes, sir.
Thank you.
One more question we can take, otherwise we will proceed to the next presentation. Okay, thank you. Thank you, Mani. Now on the line, I would like to request Mausumi Murmu.
Pointer. Okay.
Time, please. You can start.
Okay. Good morning, everyone. I am Osumi Murmu. I am a third year MBBS student from SCB Medical College, Cuttack. Today I am presenting our research topic that we had conducted in our college, that is effects of social media on eating behavior and sleep quality among undergraduate medical students, a cross-sectional study. Social media has assumed a pivotal role within the intricate framework of an individual's existence in this current era. In India, there are more than 600 million active internet users, out of which around 467 million are active social media users. Indians, on average, spend about 2.4 hours on social media daily. Undergraduate medical students use social media for various purposes in the academic setting. Evidences increasingly support the relationship between social media use and various features of the young population, including sleep, eating behavior, and mental health. So we had two objectives for our research. First is to assess the effect of social media use on eating behavior and sleep quality among undergraduate medical students. Second, to determine the association between social media use and eating behavior and sleep quality among UG medical students. So we had conducted this research in our college, SCB, between a time frame of August 2025 to October 2025, under all the undergraduate medical students. 100 students from each professional year were included in this study by a systematic random sampling method. A pre-designed and pre-tested questionnaire was used to collect data regarding socio-demographic information, social media use, and adult eating behavior. Pittsburgh Sleep Quality Index and Adult Eating Behavior Questionnaire was used for assessing the sleep quality and the eating behavior among medical students. Data were collected using Google Form and cleaned and coded with MS Excel 2021. We had also taken ethical approval from the Institution of Ethical Committee, SCB. So these are our results. We have seen that almost students between 17 to 20 years of age had the maximum percentage of social media use, and almost 66.2% students were male. And we had taken almost all, like for 4 years, equal amount of students, that is 100 students from a batch of 250 students. Next. Moving forward to the sleep quality, the prevalence of poor sleep quality among participants was 71%. We all know that if the PSQI score is more than 5, that means that they have poor sleep quality, and the average sleep latency among students was approximately 45 minutes. In PQSI, we had given a set of 19 questions. From there, it had 7 components in it, that is subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, sleep disturbance, and use of sleep medication, and daytime dysfunction. And we had the global PSQI score as 6.08. That means they had poor sleep quality. Next, moving forward to the eating behavior, we had measured it through adult eating behavior, and it had 2 subscales, that is food approach and food avoidance. If someone has more food approach, it means they have more appetite and they tend to be obese. More food avoidance score means they have lesser appetite and they tend to be underweight. We have seen that students who use more social media tend to have more emotional overeating and tend to be more obese. And also students who use more social media have more food fussiness also. So these are our mean scores. Moving forward, this is a result showing association of eating behavior with sleep quality and social media use. Students who have used more social media had poorer sleep quality. Almost all students use social media while studying.
Last 1 minute.
We have seen from a research, this is a research results. We have seen that the third year students tend to use lesser social media, that is the duration is less than 3 hours, and more than 3 hours. The second year females tend to use it more, and the hostelite students have used more social media. But the sleep quality is almost poorer. Concluding, 71% of students had poor sleep quality, significantly associated with longer social media use. There is a significant association between eating behavior and social media use while studying and sleep quality. A notable difference was observed in the duration of social media usage among students of different.
Your time is
over.
Okay. These were my references. Thank you.
Thank you, Mausumi.
Thank you, Mausumi, and your presentation was very good. And I saw there was one finding. Most users of social media were, I think, the second year students. Did you explore why it is like that? If it is possible in future, maybe you can explore. Is it same for all the students, or it is particular only for your college? You can explore.
Yes.
Maybe other colleges they can also do. I'm not sure about what happens in engineering colleges, but does something happen in second year?
Why second year? Why second year they have a more social media use? You found?
We have found
What
in
you
our
have found
research.
then? Why? There may be the Okay, good.
Good, right. So, one is you told about the eating behavior. Impact, any other impact, social, this now social media, a lot of impacts on especially student or any other adolescents. What are the other impacts of social media? So that is one. So what you told. So when you are telling second year, third year student, so they are having much more influence. So what is the cause? Why they are not the others? Fourth year and first year they are hardly. They are encountering, they are having this eating disorder. Especially that is also in boys rather than girls. What could be likely cause? Why they are taking more or what?
Girls are using more social media.
Do you know any other impact of social media over this adolescents?
Yes, definitely. So
that
there
is one. Any other impacts? There are a lot of impacts nowadays with that a lot of behavior changes are occurring, especially mental changes among the adolescents. Okay, thank you.
Yeah, Mausami, very good presentation. Regarding the methodology, I want to know, what is the duration of your study? Only 3 months.
Yes.
Then the questionnaire, you have given them questionnaire, or you have observed them, or how you have arrived to the conclusion that these are the students, these are the sleeping pattern, these are disturbance. Questionnaire you had given, or how you
we had made a Google form.
Yes.
And we had a set of questions regarding the sleep quality and the adult eating behavior, and we had sent it in our official WhatsApp groups, and randomly students have to answer the questions. Like Pittsburgh sleep quality test, there are scores like 1, 2, 3, 4, 5 square, whether a particular question, like at what, I'll take example of sleep latency, for example.
Okay, got your answer.
Yeah.
So, is there any chances of biasness there? My point is, this is a research study. Because this is an established fact that if you use the social media more or mobile more, so the sleep pattern will disturb. It is there. So my point is there any biasness you have this during your preparation of these slides? Do you feel that biasness? Biasness, yes. Because all will not. Suppose somebody will ask you or you will take the feedback. Somebody is
Sir,
using means.
Sir, may I
definitely
comment
there.
about that, sir? Sir, these types of studies are actually done in a lot of places, so that's why there is a performer for that also. And ideally, when you go for, you yourself want to do some study, it is better to stick to the questionnaire pattern which is already established. This is the thing about studies. So you can do one yourself and others can also do. And if the similar type of results are found, then you can say, okay, there is a correlation for that. So these types of studies have been done in other parts of the country, elsewhere also. She has done in her own college. So this
Sir,
is the thing.
I can comment because this is our study. This is my brainchild.
Okay.
So what actually
Yes.
this is on public. We'll publish it. Sir, actually what we did, the Google question we have made, and we have given to the students as your biasness, so they can feel anything they can feel. So this is one of the major things, sir, you have pointed out. Any point they can give. किसी को मन किया भाई 3 दे दिया, किसी को मन किया 4 दे दिया. This is one of the major bias.
One suggestion from me.
हाँ ऐसे ही होता है. हाँ.
One suggestion from me. These SCB students, they are not at all attending classes.
Exactly.
Whether it has any relationship with the social media or sleeping quality or this eating habit. Please try to make one paper on it.
Okay, sir. Yeah, exactly, yes. Sir. We are doing this is a one study. This is actually we have done another study we are doing
in the room or they are
exactly, sir,
indulged
exactly.
in the social media.
Exactly, sir. We have scanned all the attendance in the classroom. There is the attendance sheet, attendance register.
Because definitely they are going to fail next time if they will not. Particularly social. I am asking.
So, sir, जहाँ हुए ना अबोरिन किधर का ना को पास का कौन बाबन फेल को
Hello, one more question.
One more question.
Yes. You have told about the use of social media affects the sleeping habit. Social media is one of the media, and print media also is there. Electronic media is there. Social media does not means only the use of social media or excessive use of unnecessary things in the online media, which is correct because as per the social media does not have the YouTube, because YouTube is one of the platforms where most of the time in COVID times we have utilized as a strong media for the educations. And I think social media means excessive use of unnecessary things. It is correct or only the use of social media? Social media does not belong to only the YouTube, WhatsApp, because it is one of the media which can affect the well-being of the society. Can you?
Yes.
Sir,
I will give an example.
Example you can give.
Yes. It's about how we use. I'll give example of pressure. Pressure can burst pipes also, but the same pressure can convert gold into diamond. We can use social media as our aid to connect with people, to explore what is outside our worlds, and we can use it in a negative way also. We can doom scroll, waste our time on reels, and use other unnecessary
That
contents.
is misuse of online media is one of the cause which can affect the sleeping habits.
Sir,
Thank
sir, there is a beautiful finding. We are with this sir's question. So this is you can see here. This is a beautiful finding. So you can see duration of social media use less than 3 hours, and it is more than 3 hours. Here we can see those who are using more than 3 hours, around 53%. They are using more than 3 hours, but they are using during the study. You can see here social media use while studying. They are using more than 3 hours, but they are using around 53% of the people they are using social media more than 3 hours because they are using for the study, as you have mentioned. And here you can see those who are not using the social media less than 3 hours, then only 63% of the people they are not using the not for the study. So this is obvious from our study that, sir, sir, there is no significant among the first year, second year. For the first year also, for the year of the study, this is significant finding, sir. You can see, sir, duration of the social media is more than 3 hours among the second year students, those second year students. Because one might explanation will be that in the second year people, they are, from the first year they are welcome, they have some liberty. They might use the union also, they are forming the union also. So that's maybe the reason they are using more social media as compared to the other group. You can see in the third year they are, but not a nyelok kana ready chara katha. Jahan ko use ya study bakra ko use ya. Maximum people, around 53% of the people who are using social media for more than 3 hours, it's for study. This is a good thing. What we have found.
Thank you, Mausumi, for your nice presentation.
Next on the line, Aman Baden. So it's a PDF format, na? Let's see where it's opening on. You can start. Just show your title.
Good morning, respected judges, seniors, juniors, and my batchmates. My name is Aman Baden Maji, a third year MBBS student from SCB Medical College, Cuttack, and my topic of presentation is tetanus.
Judges, sorry to interrupt. Along with us are 2 more judges or chairpersons. I can invite them. Horopriya madam is there, I think. Horopriya madam, noting in Thangana. और सारो पानी हमरा मैडम के नहीं जगह ना. हाँ मैडम प्लीज. आ जाइए आप लोग प्लीज काइंडली बी ऑन टू द स्टेज. अगेन reschedule the time please. हाँ है सर है. हाँ मैडम आप उधर बैठ जाइए. हाँ दिस इज द स्कोर शीट. अभी तो नोट कैन हैव बीन मैडम. हाँ आप मैडम यहाँ से स्टार्ट करिएगा. हाँ यू कैन स्टार्ट फ्रॉम दिस प्रेजेंटेशन. हाँ सर व्हाट आई हैव शोन फ्रॉम द 3 years I am attending the SDACON. This year presentation is quite we have level gone to the level up from last year's presentation. Say definitely we will action one day in the National International Forum, I think. So judges, we can start. Speakers, sorry, chairpersons, we can start.
Good morning, respected judges, seniors, juniors, and my batchmates. My name is Aman Baden Maji, third year MBBS student from SCB Medical College, Cuttack, and my topic of presentation is tetanus. Tetanus is caused by Clostridium tetani. It is a gram-positive, strictly anaerobic bacteria, and it releases exotoxin, spasmin, and tetanolysin. Due to this release of the exotoxin, it binds to the sites which inhibits the release of the inhibitory neurotransmitters, which leads to the prolonged contraction of the skeletal muscle fibers. Its epidemiology is its reservoir is soil, dust, animal feces, sewage water, and transmission can occur through inoculation, direct contact, or droplet infection, or it can also occur through transplacental pathway. Its incubation period is of 6 to 10 days to weeks, or it can even take months. The neonatal tetanus cases have been reduced to less than 1% per 1,000 live births in districts due to commencement of various safe delivery practices, immunization, and various public health programs. but adult non-neonatal tetanus cases still occurs, roughly 4,900 cases reportedly per yearly. This is a graph showing the DPT-3 coverage in India according to WHO over the period of year. It's covering more than the 90% of the area. This is another graph showing that the death rate has been reduced in India and all over the world. Pathogenesis. So Clostridium tetani spores enters the body through an infected wound or any major road traffic accidents and or any other pathway. So it enters the body and it is in sporulated form. When it gets the anaerobic conditions, it germinates and multiplies and produces the tetanus spasmin toxins, which travels through the blood and lymphatic system and binds to the motor neuron. It travels along the axon to the spinal cord and binds to the site, which is responsible for the release of the inhibitory neurotransmitters. So the patient will present with the clinical features such as the main symptoms that we will see is trismus, lockjaw, opisthotonus, rhizus sardonicus. Other symptoms like febrile irritability, heavy sweating, headache, difficulty in swelling, difficulty in breathing. There will be a spasm of the facial muscles. This is the most common system, tetanic triad. Rhizus sardonicus, it is the spasm of the facial muscles. There will be a grin smile. Then trismus, lockjaw, which is the spasm of the masseter muscles. Opisthotonus, which is the spasm of the extensor of the neck, back and the legs, leading to a backward curvature. The complications that the patient will present will be, there will be due to the severe spasm, the spine and other bones can break. And during the treatment of this tetanus, powerful sedatives are used, and due to the use of these sedatives, the prolonged immobility of the muscle will be there, due to, which can lead to permanent disability. Other complications like laryngospasmy, means the larynx will spasm, which will lead to breathing difficulty. Then aspiration pneumonia can occur, in which the contents of the stomachs can be inhaled, leading to lower respiration tract infections. And if the infection spreads to the brain, it can lead to tetanic seizures. Diagnosis is generally diagnosed with the clinical features that the patient presents with, like rhizus sardonicus, opisthotonus, trismus, lockjaw. Laboratory diagnosis is not much very helpful.
1 minute more.
Management is, we focus on managing the complications of the tetanus. First, if the wound is not very deep, it is cleaned thoroughly, and if it is a very deep wound, surgical intervention may be needed. And if it is a tetanus prone wound, tetanus immunoglobulin is immediately given even if the patient is vaccinated. Antibiotics is given such as penicillin and metronidazole to prevent the bacterial bacilli from growing, and but it does not has an effect on tetanus spores. Anticonvulsants can be given like diazepam, lorazepam to treat the muscle spasms. This is showing the most common system as the lockjaw. And if we see the cases in urban and rural areas are more prone, as people walk on barefoot even after a foot injury, and due to lack of awareness, instead of going to doctors, they go to the faith healers. Prevention, it can be prevented through immunization, active immunization and passive immunization. Active immunization is through like combined vaccines giving DPT, and monovalent vaccines can be given like tetanus toxoid. Passive immunization is giving immunoglobulins, which is effective up to 30 months. Doses is in pregnant women, tetanus toxoid vaccines are given 0.5 ml in the interval of 4 weeks. And in newborn children, DPT is given in 6, 10 and 14 weeks, and DPT boosters can be given in 18 months and after 5 years, at the age of 5 years. And TT boosters can be given in 10 and 16
Time
weeks.
is over.
It does not spread from person to person, but it is a life-threatening, and Primitate is a passive form of immunization. Thank you.
Thank you for your presentation.
can you give TT after onset of disease?
Yes, it means we can give actually combination of active and passive immunization is given. Means TT vaccine is also given, and along with it immunoglobulins can be given.
So what is the difference between tetanus and tetany?
Sir?
Tetanus and tetany.
What is tetany and what is tetanus?
Sir is asking what is the difference between tetanus and tetany.
So my question is, so when you never get this neonatal tetanus, which age group and beyond is it unlikely?
Sir?
Up to what age or what day of life? So you never seen, never occurs the neonatal tetanus, and thereafter certain period are said there. So thereafter also unlikely to have any case of neonatal tetanus.
It can occur in
3 दिन गिद्रे खना 3 दिन भीतरी क्या हुई 3 दिन टाइम परमलेंट खांदो neonatal tetanus तो मैं हुई ऐसा तो
it can occur after the birth, means it is also called 8th day disease, because its symptoms are seen after the along the 7th day, and it can occur anywhere. So
maximum by 3 days. So after 3 and beyond 14 days is unlikely. So that usually never occur before 3 days of life. So thereafter, after 14 days, you are unlikely to have any case of tetanus, neonatal tetanus. Second question is, so you are showing the surface tetanus posturing. So that is also seen in a case of decorticated posturing. So how did it differ? Decortic because of central origin, or due to whether it is due to tetanus? Chelakaram bada dale another tetanus can say office tetanus posture second decelerated posturing in the coma stage, last stage. How did you know? What is the difference? What is basic difference between tetanus and this decorticated posturing?
I'm still stuck.
So here sensory is never lost in a case of tetanus till the death. So usually patient remain alert, but in other cases, so patient will not respond to or comatose state. Okay, thank you.
Tetany is due to deficiency of what? Calcium. Hala?
Yes, sir.
But around 10 to 15% of cases don't have history of injury. So
third year kram to nothing to learn. Koya kata na niyati kata muscle sila to koi pariwa na. Koya nahi. Pharmacology पढ़ाई थी ना मैडम. Pharmacology
पढ़ाई में उठे वो.
पढ़ाई नहीं.
पढ़ाई
अच्छा अच्छा ठीक है. Central group of muscle relaxation. Okay.
ट्रीटमेंट तो बाको बड़ा क्या है?
अच्छा बाको बड़ा है का.
Okay, so we'll move on to the next speaker. She is Sunita Tudu, third year student from PRM MCH. Please come on over to the stage.
Imagine a 6-year-old boy walks into the OPD with nothing but a high fever and slight confusion. In a busy clinic, you might think it's just a common flu, but in a few hours, he's in a coma. This isn't just a fever, it's a sequestration crisis in the cerebral microvasculature. Today, we aren't just talking about the parasite. We are talking about its race against time. Good morning, everyone. Myself, Sunita Turu, a third-year MBBS student from PRM MCH. And today, the topic of my talk is malaria, the silent scourge. So, malaria is a life-threatening disease, protozoal disease caused by a small parasite, Plasmodium. And let's see what threat it poses globally. The latest WHO data reveals a stalled progress globally, making it a critical talking point. Approximately 282 million cases globally in 2024, an increase of about 9 million from the previous year. Roughly 610,000 deaths annually. The WHO African region still accounts for 95% of all cases and 95% of all deaths. The climate change, expanding mosquito habitats, and the spread of Anopheles stephensi and urban-dwelling mosquito are emerging risks. Meanwhile, the Indian scenario is on the good side. It is a success story. India is an outlier in the global trend, showing significant progress despite being a high-burden country historically. India has seen a 80% reduction in malaria cases and deaths between 2015 and 2024. The 2024 statistics reveal approximately 227,000 cases and 83 deaths nationwide. In India, both Plasmodium falciparum and Plasmodium vivax are prevalent, but Plasmodium falciparum currently accounts for for the majority of the cases. The transmission is no longer nationwide, it is now concentrated in the pockets. The high-risk zones of India are Odisha, Chhattisgarh, Jharkhand, and the northeast states. Now, let's talk about the epidemiological factors, which are agent factors, host factors, environmental factors, and the vector, the bridge. The agent factors are more than 12 gametocytes per millimeter cube of blood are the relevant threshold to diagnose malaria. Sorry, there has been a typo. It is both gametocyte must be present in the human to call him or her infective. The reservoirs are humans, monkeys, apes, and other primates. Source of infection is infected mosquito and humans. Extrinsic incubation period, gametocyte transforms into sporozoid within 10 to 12 days. The host factors are the age. Children under 5 are at the highest risk due to lack of acquired immunity. The pregnancy reduces immunity, making mothers more susceptible to severe malaria and anemia. Forest workers, farmers, and people sleeping outdoors have higher exposure. The environmental factors are climate. The temperature, the ideal range is 20 degrees Celsius to 30 degrees Celsius for the breeding of the mosquito. High humidity, that is more than 60%, is favorable for mosquito breeding. Rainfall creates stagnant water pools for mosquito breeding. Poor drainage, irrigation projects, and urban malaria caused by construction sites and water tanks are favorable for mosquito breeding. The vector, female anopheles. Only the female bites cause malaria. Most of the the feeding habit of the female Anopheles mosquito is nocturnal. That is, the biting is done between the dusk and dawn. Now it's a beautiful diagram of the cycle of the plasmodium life cycle. Infected mosquito, when it bites a normal human, it injects sporozoids via the bite, and the sporozoids get into the human's body. The sporozoids eventually enter its targeted organ, the liver, and they rupture the liver cells, and the merozoites are released. I'll skip this diagram because we all must be aware of this diagram. The clinical features are headache, malaise, fatigue, nausea, muscular pain. Acute febrile illness may have periodic febrile paroxysms every 48 to 72 hours with febrile asymptomatic intervals. Anemia, thrombocytopenia, jaundice, hepatosplenomegaly, respiratory distress syndrome, etc. The diagnosis, the microscopic examination of blood film, that is thin and thick smear, are the gold standard. Rapid diagnostic tests kits are also available in for treatment. For uncomplicated malaria, for acute attack, we give oral chloroquine, which is the drug of choice. Sorry. And for acute attack due to Plasmodium falciparum, we give ACT regimen plus Primaquine. For severe complicated P. falciparum malaria, we give artesunate.
1 minute left.
In pregnancy, we give P. falciparum. For P. falciparum infection, we give in the first trimester we give oral quinine salts. Second trimester we give ACT and artemether lumefantrine. In P. vivax infection, we give chloroquine, which is the drug of choice.
Okay, your time is over now. Any questions from audience?
What is the characteristic features of fever in malaria? What is the character of fever in malaria? Pattern of fever.
Sir, a person presenting with malarial symptoms, he'll present with intermittent
I am asking about only fever.
Sir, it
Nature
is
of
intermittent and chills and rigors are associated with it. And
but you have mentioned the slight fever. What is that? That slide, in one slide you have mentioned. In one slide you have mentioned slight fever in clinical picture. Show me the clinical picture slide. The slight fever, what is that? Slight fever.
Sir, these are the
not
early symptoms.
intermittent.
These are the early symptoms.
Usually not intermittent.
For your level, do not use any adjective too much. Slight, mild, all these things are not for you. They are for clinicians, those who are experienced, because you cannot explain these adjectives. So avoid the use of adjective in oral, in clinical, in presentation also, because usually this loose motion and all that diarrhea symptoms are complications of falciparum malaria, that is known as algid malaria. That is the one complications of falciparum malaria, and the continuous type of fever you can get when your infection is both for vivax and falciparum combined. But typical one type of malaria organism, parasite causes intermittent. Typical example of fever is malaria is intermittent fever with chill and rigor. Okay, understood.
Thank you, ma'am.
Sunita?
Yes,
I have a question.
So my question is, which is the gold standard for diagnosis of malaria?
Sir, the microscopic blood examination testing, that is the thin and thick smear, is the gold standard for.
Okay, so you are very thick and thin smear, it is usually taken.
Yes, sir.
So why there are different smear are taken? What is the need of taking the thick and thin smear in a case of detecting malaria?
Sir, with thin smear, we can know about the species of the plasmodium, and with thick smear we can know about the sensitivity.
So one a thick smear to detect the species. Regarding thin smear, you can able to identify the which genesis. That means which particular organism you can. So last question is why you are giving the primaquine for 14 days in case of Vivax? Why not a malaria? Why not a falciparum? Why you are giving for 14 days of course of 14 days? You have shown in your slide. So you must give primaquine for 14 days. For falciparum you can give a one single dose. So what is the need? Why you are giving the curative or radical treatment? What is the need for that? Okay.
Sorry, sir, I need to read more.
So radical treatment to cure this sleeping stage. So that is usually present in Vivax. It is not found in case of falciparum. So that's why you have to eradicate the organ. So for radical treatment, you have to give the primaquine for 14 days. Okay, thank you.
Thank you, sir.
For nice
Sunita, I have a
presentation.
question. What is the most common form seen in the blood picture of a malaria parasite?
Ma'am, the ring form is the most common.
Can you differentiate between malaria? How can you differentiate the ring form of that malaria falciparum and Vivax?
Ma'am, the P. falciparum, the person infected with P. falciparum shows the classical ring formations,
yes.
And P. Vivax, it shows
that is also ring form, but size is
more,
different.
yes,
Size
ma'am.
is different.
Size is
That's in malaria it is smaller, and
Yes,
in
ma'am.
Vivax it is bigger. Okay, thank you. Thank you,
ma'am.
Sunita.
Thank you, ma'am. Thank you, sir.
Hello. My question is, you told malaria fever is caused by female Anopheles.
Yes, sir.
But why not male Anopheles? Male mosquito? Any reason? Because male mosquito is not sucking blood. Its food is dependent on rotten fruits. Thank you.
Thank you, sir.
Okay, so we'll move on to the next speaker. Okay. Please, sir, carry forward.
Question is very simple. Government has announced so many schemes for the eradication of malaria or any disease. Any other guidelines is there? So malaria-free nations, when India will be the malaria-free nations by 2030 or 2047, because it's Bharat, or which year it will be, because we know as long as mosquito will be there, there is a fever, there is a malaria. Any guidelines is there, government's guidelines, when it will be free from India, malaria-free India?
Sir, from what I have studied for this presentation, what I know, the NVBDCP program of the government, with currently known as NCV BDP, it says by 2027 will eliminate malaria.
Okay. Thank you. Good.
Thank you, sir.
Okay, Saras, please come over to the stage.
Hello. First of all, good morning, respected judges, doctors, professors, and my seniors, juniors, and thanks for giving an opportunity to introduce myself, Saroj Majhi, second year MBBS student from DDMCH Keonjhar. So my presentation topic is thalassemia. The specific objectives, introduction, classification, causes, common features, investigation, treatment, prevention, and final conclusion. So what is thalassemia? Thalassemia is a group of inherited disorders caused by deficient globin chain synthesis due to mutation in globin chains. The prevalence of thalassemia. Thalassemia is a major health issue in India with an estimated 3 to 4% carrier rate for beta thalassemia, around 35 to 45 million carrier, according to Press Information Bureau and National Institute of Health. Key reason for high prevalence, high carrier frequency, endogamy, lack of awareness and screening. Normal hemoglobin, adult hemoglobin HB, it is a tetramer composed of 2 alpha and 2 beta chains. In hemoglobin A2, it consists of 2 alpha and 2 delta chains. In fetal hemoglobin, it consists of 2 alpha and 2 gamma chains. Thalassemia is a 2 types, alpha thalassemia, beta thalassemia. Alpha thalassemia again divided into silent carrier, alpha thalassemia trait, HBS disease, hydrops fetalis, and beta thalassemia 3 types, major, intermediate and minor. Clinical classification of alpha thalassemia in silent carrier is a clinically and hematologically normal. In thalassemia trait, microcytosis, hypochromia and mild anemia. In hemoglobin H disease, the moderate to severe microcytic, hypochromic, hemolytic anemia, mild jaundice and moderate hepatosplenomegaly. HB bars hydrops fetalis syndrome, severe anemia, generalized edema, ascites, marked hepatosplenomegaly. In beta thalassemia major is a hereditary hemolytic anemia due to absence of synthesis of beta globin chains, few or no beta chain synthesis, defect in both genes or homozygous. In beta thalassemia minor, more common than beta thalassemia major, usually asymptomatic and mild anemia, defect in single gene, that is heterogeneous. Causes: inherited genetic mutation affecting hemoglobin production, alpha thalassemia, deletion of one or more alpha genes located on short arm chromosome 16, beta thalassemia, point mutation of beta globin genes resulting from single base chains. 3 types of mutation: splicing mutation, chain terminator mutation, promoter region mutation. The common features of thalassemia like anemia, jaundice, hepatosplenomegaly, hair on end appearance on skull X-ray, growth retardation, iron overload. Investigation: decrease in hemoglobin, MCV, MCH, and peripheral smear, microcytic, hypochromic, hemoglobin electrophoresis, genetic testing. Treatment is blood transfusion and iron chelation therapy and also stem cell transplant. The prevention of thalassemia like carrier screening, like premarital screening, antenatal screening and genetic counseling, especially in high risk population, avoid consanguineous marriage. And also we all celebrated World Thalassemia Day, that is May 8, National Program for Control of Blood Disorder, NPCBD, to address blood disorders like thalassemia. It involves awareness campaigns, screening programs, and the provision of blood transfusion service. Thank you for your attention. Early diagnosis by hemoglobin electrophoresis, and prognosis and quality of life. Thank you.
सरोज थैलासेमिया इन्वेस्टिगेशन रे आर्मिटी इन्वेस्टिगेशन बाम ले लिया है माने फाइनल डायग्नोसिस चल करे हुई है
Question again, please, ma'am.
Sir, investigation he has written CBC, peripheral smear, hemoglobin, and genetic. One more test I want to know. One more test is there.
You know, then one more test is there.
Very important test, which you have left out.
No, look, if you don't know, then don't worry. There is so much of time you can read.
But you should have written it. At least UG should know also. HPLC.
Yes,
High performance liquid chromatography.
Yes, ma'am.
By that you can differentiate alpha thal or beta thal. I didn't see. Last slide.
Yes, sir. High performance liquid chromatography.
Oh, attention. Clinically, केमिति differentiate करियो thal major and thal intermediate, thal minor.
In your slide, you shown you go to your clinical pictures. So you have written the jaundice. Can it jaundice is possible in case of thalassemia?
Yes, sir.
You are telling thalassemia. So where is the basic defect in thalassemia?
In case of
Why there is
thalassemia,
thalassemia occurs?
in case
Already you mentioned, okay. So there is defect in the production of alpha thalassemia. Where is this? That means hemoglobin itself is defective. So when the hemoglobin got matures, after coming out to this from coming to the circulation. So whatever in thalassemia, that usually in effective erythropoiesis, before liberating this come to the circulation, usually they get destroyed inside the bone marrow. So hardly they is to come to this before coming to the circulation. So this case usually jaundice never occurs unless it is infected or there is secondary complication. Only that is the case of sickle cell disease where the jaundice is very common.
Yes,
So okay, another second question. So you are saying most of cases are beta thalassemia, not the alpha thalassemia. Why not the alpha thalassemia? Both are there, both alpha and beta. So here beta thalassemia we commonly encounter the beta thalassemia, not the alpha thalassemia. What is the reason? Can you explain?
no, sir. I will read and tell.
Why there is alpha thalassemia is not seen in case of hardly we see the alpha thalassemia, mostly beta thalassemia. What is the reason? Okay, so because alpha thalassemia, usually those patients died soon after the birth or inside the or prenatal death. Fetal death occurs or soon after the birth. So they never come, they never go beyond this infancy. So hardly you would be able to detect. Okay, thank you.
Okay. By the actually, he must be. I congratulate you because being in second year MBBS, he has tried the thalassemia. So big thanks to him. Okay. Okay, Babu, metang questioning kulimia thalassemia. What is the lifespan of RBC in these thalassemia patients?
Sir, normal lifespan of RBC is 120 days.
Very good.
Very good.
Very good, very good.
Very good, very good. What is the lifespan of this RBC in thalassemia case? No, the answer again. छोटा question है.
और ठीक है सर, ठीक है.
In case of thalassemia, there the RBC lifespan is
ढेरों आचे कोमोगा हुई.
less.
Less. How much it is less? 90 days. Anybody in the audience?
I think 90 days.
अल्लाह master हॉल करना तो लकुली जों को अलग करी question. भाई यहाँ पे कोई को तो ना पे हमारा.
90 days. 90 days.
Audience, what is the lifespan in case of sickle cell disease? कौन हवा? और thalassemia कौन हवा? बाह, ये जो बताओ.
Lifespan RBC.
Okay, it is 20 days. Okay, it is 20 days.
20 days.
Thank you.
Thank you, sir. Thank you.
Do shortage of time.
Suraj, I have
So
a
will-
question. Suraj, I have a question. You showed in your slide that microscopic hyperchromic picture, huh?
नहीं मैडम.
थिला
थोड़ा
peripheral
देखिले,
smear.
just see.
Peripheral smear थिला. Peripheral smear. Microcytic hyperchromic anemia. थिला.
अच्छी आको आरे आको आरा आको आरे आको
एटा अछि micro.
यानी से आगरे बेच से आगरे बेच
खाई जे पिक्चर नहीं हाँ.
What is microcyte?
Microcytic, less size of RBC. Normal size of RBC less than.
चेल कम ठीक दाड़िया आज ये उना तो microcyte का नाम है चेल सलेम compare in peripheral smear.
In peripheral smear, we compare with the lymphocyte.
अच्छा lymphocytes ला दो compare.
Yes.
सूर गया चे मारंग गया चे हुडिंग गया उनका चेल में ना.
Yes,
चेल
small size. than lymphocyte.
about pakha pakhi ya ठीक है microcyte arched slash cell target cell anjama target cell
Yes.
target cell what is that target cell पढ़े
पिलाटा को बेसी टॉर्चर हे गला मैडम
हां ठीक
पिलाटा को बेसी रैगिंग हे गला
थैंक यू सरस मैम थैंक यू
Thank you.
So Podiva, good. It's a good thing that so much of interaction in this session. So this type of interaction we actually need, but due to lack of time, we are not facilitating. So thank you chairpersons and judges for nicely conducting the session. And I will give you some bio break. After that, I will again invite you people to complete or 3 or 4 presentations are there. So I will request you people. All the speakers and judges kindly collect your score sheet and have with you all update के तहन में और हिसाब किताब का था एमएलए पे आर पे प्रेजेंटेशन में ना नहीं तो आई विल रिक्वेस्ट यू पीपल हाँ फॉर हाँ ब्रेक नुकु नुकु मैडम बकरा फॉर द मैडम देयर हाँ थैंक यू चेयरपर्सन्स थैंक यू जजेस आर दड़ा नहीं हुआ पे आर पे में ना को नहीं तो कोई ब्रेक की दिक्कत पे थैंक यू
Now, we are going to have a very important session. I request everyone who are present outside the hall, please come inside the hall. Now we have our guest speaker, Dr. Milan Kumar Satpathy, who is a cardiologist. And after that, we have a session on financial planning, which is very, very, very important for every one of us. So don't miss it. I request everyone to take this opportunity to learn. Before that, I want to announce that one of our friend, I can say, he is not other than Mr. Ashok Kumar Turuk sir, who is the professor and HOD of Department of Computer Science, NIT Rourkela, who has helped us immensely to get the auditorium approved by the authority and clearing the security related matters and various other matters also. So I request everyone to have a big round of applause for him again. I request Mr. Turuk sir to please come over to the dais.
हाइड कर दो ना प्रेजेंटेशन हाइड कर दियो
I want to add that I want to correct myself that sir is also the Dean of Academic NIT Rourkela. Now I invite our President SDA Odisha, Mr. Chaitan Maji sir, to the dais.
ଅଧିକାର ଅଛି ତ ପଚାର ଦେଇଛୁ ଟିକେ ଅଭ୍ୟାସ ହେଇଗଲାଣି ସେଠି ସେଟା ନ ପଚାରିଲେ କେମିତି ଲାଗୁଛି ଏବେ ସବୁ ଏକ୍ଜାମ ଗୁଡ଼ା ପୁଣି ନେଉଛି ଫାଇନାଲି ପିଟୁ ହେଇଯାଇଛି ଥୋଡ଼ କ୍ୱେଶ୍ଚନ୍ ଗୁଡ଼ା ଖାଲି ଘଡ଼ 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 ଖାଲି ବାହାରୁଛି ଖାଲି ଗୋଟେ ଜିନିଷ କ'ଣ ହେଇଗଲାଣି ଏବେ ସବୁ 2018 ଷ୍ଟାର୍ଟ ନା 2018 ଶଶି ସାରଙ୍କର ଷ୍ଟାଇଲରେ ପଚରା ହେଉଛି ହେଇପାରେ
Now I request our president to felicitate Professor Ashok Kumar Taruk.
ମୁଁ ଭାବୁଥିଲି କାଲି ତମ ଟକ୍ ଥିଲା ନା ଗତକାଲି ଟକ୍ ଥିଲା ମୁଁ ପହଞ୍ଚିଲା ଲେଟ୍ ହେଲା ମୁଁ କହିଲି ସାର୍ ମିଲନ କଲା ମୁଁ ଆଉ ରଖିପାରିଲିନି ତମକୁ ଗୋଟେ ଦିଆହେବ ସେମିତି ଟ୍ରାଡ଼ିସନ୍ ଗୋଟେ ନେଇକି ଯିବ ଏମିତି ଗୋଟେ ଦେବ ନା ପିନ୍ଧିବ ହେଲା ଏ ମିସେସ୍ ଏଇଠି ନା ଭଲ ବହୁତ ଥଣ୍ଡା ଭାଇ ରାତିରେ କି ଥଣ୍ଡା ଭାଇ ଭୟଙ୍କର ମୁଁ କହିଲେ ଆମେ କିଛି ବି ଆଣୁନୁ ମୁଁ ଆମେ ଯେଉଁ ଗେଷ୍ଟ ହାଉସ୍ରେ ଅଛୁ ସେ ଯେଉଁ ଗେଷ୍ଟ ହାଉସ୍ରେ ଯେଉଁ କମ୍ବଳଟା ଦେଇଛନ୍ତି ମାନେ ସେଇଟା କ'ଣ କହିଲ ନା 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 ସେଇ ଯେଉଁ ବାହାରେ ବାଣ୍ଟନ୍ତିନି କି ହଁ 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 ହେଲା କେତେ ହେଲା କ'ଣ କରିବା ଆକ୍ଚୁଆଲି ଆମେ ରାଧିକା ଏଜେନ୍ସିରେ ଇଏ ଥିଲା ବୁକ୍
Thank you, Professor Ashok Kumar Taruk sir. Our friendship will remain forever. Thank you.
So moving forward, along with us, Dr. Milan Satpathy sir, he is a cardiologist in the Apollo Hospital. Sir is with us. So listen from him on the approaches to SCS in peripheral setup. What is the approach for the SCS? So to speak on this, I will invite Dr. Milan Satpathy sir to kindly come onto the stage.
Namaskar.
So to chair the session, I would like to request Professor Malati Madam Murmu. Professor Malati Madam Murmu, kindly come onto the stage. Dr. Dukhya Murmu sir, please have a seat on this stage. Along with this, I would like to invite Hare Krishna Maji sir. Please sir, proceed onto the stage. So stage the bijod gen hello kana. So for public demand, I would like to request another chairperson from the public demand.
So now we are having.
Sir, आप इधर सर पढ़े आसिए प्रफुल्ल मांझी सर मेडिसिन वाला हाँ सर प्रफुल्ल मांझी सर फ्रॉम द पब्लिक डिमांड प्रफुल्ल मांझी सर काइंडली कम ऑन द स्टेज सर नतर ही हरे कृष्ण सर आप एपटे पड़े आसन दिजन
So now we are having a topic on discussion regarding coronary artery disease, that is a acute coronary syndrome and its management in peripheral center. So just brief review about topic, that is coronary artery disease. Spectrums are stable angina pectoris and unstable angina pectoris, non-ST elevation MI, ST elevation MI, and MI during intervention or post-interventional post-CABG. So he will be highlighting in management in peripheral center, MI and its management. Because in peripheral center, just now I talked with Dr. Satpathy, he was saying in district headquarters also thrombolytic therapy is free of cost, government is supplying. So diagnosis is very, very important for everybody, how to diagnose from ECG, and subsequent investigation may not be available, but time is very limited. We can treat appropriately during golden period only. That's why it is important to diagnose MI in peripheral center so that we can manage properly and we can save many lives. And regarding speaker, I am privileged to introduce my intelligent, balanced, most balanced student, ex-student of mine, Dr. Milan Kumar Satpathy. He is very, very intelligent, very obedient, very organized, and he will be talking very appropriately, which you can imprint in your brain and you can use in future. Please, Milan, you can start it now.
So, thank you, ma'am. Good afternoon, all. I am very much thankful to SDACON, especially Murmu madam, Hemram sir, Maji sir, Durga Maji Murmu bhai, for giving me a chance to talk something about the management, which is most deadly, most serious conditions in our life, that is myocardial infarctions. When patient comes to us in emergency, in tertiary care center, it is very easy to manage those kind of patients because all the facilities for the diagnosis and investigations as well as the option for angiogram and angioplasty is there in tertiary care like corporate setup. But it is very difficult that when a patient comes to us with a very deadly condition, with a very severe chest pain in peripheral setup, like PHC or CHC, where it is very, rare that ECG setup may not be there, the diagnostic setup may not be there. It is a very distant from that PHC or CHC to a corporate center where angiogram, angioplasty is available. So in the midnight, when a doctor in PHC or CHC, we are very much thankful to them because when they diagnose a patient with only the clinical history, and for them, it is we are salute them because at that setup, only the science, only the clinical history, physical examinations, it is very crucial to diagnose that this patient may have the myocardial infarctions. And accordingly, we treat that patient in that center. But thanks to government, nowadays it is the many of the investigation tool, the basic investigation tool, that is ECG, and the thrombolysis. Now it is available in some of the CHC as well as district headquarter hospital free of cost. So nowadays, the most important thing when we treat a patient of myocardial infarctions, the most important thing is the diagnosis. Because many a times, the patient undergo a deadly complication or death is because we cannot diagnose a patient is having myocardial infarctions. आमे मैंने जत्ते बड़े गोटे पेशेंट को रिसीव करूँ इमरजेंसी डिपार्टमेंट रे कोठी भी आपण थांतु पीएचसी रे थांतु सीएचसी रे थांतु इट इज वेरी इंपोर्टेंट दैट पेशेंट इज हैविंग माइक्रोडल इन्फेक्शन एटार माइक्रोडल इन्फेक्शन हेची at 2 AM जतले राति रे गोटे पेशेंट आसुची चेस्ट पेन पई आमे सेटा को डायग्नोसिस करबाटा सबुठ इंपोर्टेंट तापर तो ट्रीटमेंट स्टार्ट हबो सो इफ वी कैन नॉट डायग्नोज अ पेशेंट ऑफ माइक्रोडल इन्फेक्शन एट दैट सेटअप पेशेंट डाइज देन एवरी केओस स्टार्ट्स देयर कि डॉक्टर जानी पारलानी डॉक्टर करि पारलानी ईसीजी भी अच्छी बट वी कैन नॉट आइडेंटिफाई माइक्रोडल इन्फेक्शंस सो बिफोर गोइंग टू द ट्रीटमेंट प्रॉपर like your antiplatelet therapy, anticoagulant therapy, angiogram, angioplasty, the basic thing is we should know the symptoms first. We should know or we should diagnose a patient is having a myocardial infarction in ECG. So the two things is very important before the treatment part. So coming to the chest pain, we know that all the chest pain are not anginal pain. The pain which is from our thorax or chest cavity, the patient perceive as a anginal pain, but all the chest pain are not an anginal pain. So we have to first diagnose the chest pain which is from the heart is anginal pectoris. जोटा heart रो create होची सेही chest pain टा anginal बा angina pectoris बा heart pain बा myocardial infarction pain. So there are many structures in thorax like heart, lungs, the vessels, the muscles or chest cavity muscles, from each organ, from each part of the thorax, the patient can perceive pain. But we have to diagnose that pain is from the heart, or that pain is an anginal pain or angina pectoris pain. So from heart, the patient may have myocardial ischemia or myocardial infarctions, may have a pericarditis, the inflammation of the pericardium, the covering of heart. It may be from vascular point, that is aortic syndrome, aortic dissection, maybe from pulmonary embolism. So these things are there from where we can have, when the patient perceive pain. But those pain are not anginal pain. Make it clear, the pain is from myocardial infarction, the ischemic frame from the heart is called anginal pectoris. Many times patient comes to us with esophageal reflux, spasm, ulcer, costochondritis, Treace syndrome, and many times it is also psychological. But what is important? So 10 to 15% of acute chest pain is from acute coronary syndrome or heart attack. So if we cannot diagnose that patient, it will end up into many complications of heart attack and leads to death. So it is a very serious condition. So we have to first think that what is angina, or what is the chest pain which is from the heart. So as you all know, anginal pain or chest pain, literally it is not a pain, it is a discomfort. Many times patient comes to us, sir mate bhal laguni kahi kali rati ru chhati ta gote kemti laguchi bhal laguni. That means it is a discomfort, it is not a pain. Which type of discomfort? Sir mate heavy laguchi, ଟିକେ କେମିତି ଚିପି ଦେଲା ଭଳିଆ ଲାଗୁଛି, ପ୍ରେସରାଇଜ୍ ଲାଗୁଛି. ସୋ ଦ୍ୟାଟ୍ ଇଜ୍ ଏ ପ୍ରେସର ଲାଇକ୍ ସିମ୍ପଟମ୍ ଅର୍ ହେଭିନେସ୍ ଇନ୍ ଦ ଚେଷ୍ଟ, ପଥର ଗୋଟେ ଲଦି ଦେଲା ଭଳିଆ ଲାଗୁଛି. ସୋ ଦିସ୍ ଇଜ୍ ଦ ଟିପିକାଲ ଅଫ୍ ଆଞ୍ଜାଇନାଲ୍ ପେନ୍. ପେନ୍ଟା କେମିତି ଲାଗୁଛି? ସାର୍ ଏଇ ଚେଷ୍ଟର ସେଣ୍ଟର ପାର୍ଟରେ ଲାଗୁଛି, ବେଳେବେଳେ ଲାଗୁଛି ପଛକୁ ମାରିଦେଲା ଭଳିଆ ଲାଗୁଛି, ହାତଟି କେମିତି ଝିମଝିମ ଲାଗୁଛି. So this is a typical radiation of that pain. So when a pain which is a central or central pain, which is a discomfort, which is a pressurized pain, so that may be an anginal pain which is from myocardial infarctions or MI. This pain is having a characteristics radiation. So basically books says that this pain is up to the mandible पर्यंत. बेले बेले पेशेंट सिम्पटम्स कौन रुहे? सर मत खाली ना टूथाक बेले लगुच केमती some abnormal sensation in the mandible. So maybe misdiagnosed as dental caries or dental pain. But the patient after ECG, many times we see that patient is having ST elevations. So that pain may radiate into the jaw up to the umbilicus, epigastric pain. So this typical radiation, the typical characteristics signifies at 2 a.m. in the night that patient is having anginal pain. So when a patient is having risk factors like obesity, diabetes for 20-30 years, hypertension, now comes to us with this type of symptom. So first thing, the serious condition, that is myocardial infarction. It's a heart attack hei pare, because if we cannot diagnose heart attack, the patient may land up in death. So death hei jai pare. So it is good कि आमे गोटे पेशेंट रो रिस्क फैक्टर्स अच्छी, पेशेंट ओबेसिटी अच्छी, एज अधिक अच्छी, पेशेंट रो डायबिटीज अच्छी, हाइपरटेंशन अच्छी. नाउ कम्स टू अस विथ दिस टिपिकल एंजाइनल सिम्पटम. फर्स्ट अनलेस अदरवाइज प्रूव्ड, आमे जदि नाही हम पाखरे ECG भी फर्स्ट डायग्नोज इज मायोकार्डियल इन्फार्क्शन. बिकॉज अदर डायग्नोसिस, सपोज आमे सेठी इसोफेगल रिफ्लक्स कथा चिंता करिबा, जॉड कथा चिंता, पेशेंट सेतरे मरिबनी. बट आमे जदि MI कथा न चिंता करिबा, पेशेंट को सेमती छाड़ी दबा एट द पेरिफेरी सेटअप, पेशेंट पुणी आसीबो ब्रॉड डेड. So we have to think first that it is a myocardial infarction unless otherwise proved. So the intensity of the pain, मते फास्ट टिके केमती लागिला, तापर पेशेंट कोन करंदी पांटोप्राजोल गोटे नै गले, टिके बेटर लागिला. बट धीरे धीरे पेशेंट रो इंटेंसिटी, द पेन इंटेंसिटी ग्रेजुअली इंक्रीजिंग, क्रेसेंडो. इट मे परसिस्ट मोर देन 20 to 30 minutes, 20 मिनिट रू 30 मिनिट पर्यंत. नाई आज्ञा पांटोप्राजोल खाइले भी मते भल लागुनी, मते सेमती ही सिम्पटम्स लागुची. सो द क्रेसेंडो, इट इज अ वेरी कैरेक्टरिस्टिक ऑफ myocardial infarctions or angina pectoris. And it may precipitate because of heavy exercise, psychological stress. बेले बेले पेशेंट आसंती ब्लड प्रेशर 220 230, that is accelerated hypertension. So in that situation, it associated with myocardial infarction. So these are the characteristics of anginal pectoris. So we have to think in that way that this type of symptom may be there, radiation will be there. But what are the uncharacteristic? Kota heboni, myocardial infarction eta hei pariboni. Kono? The first is the localized pain. Again, more in the left side, it would have chest pain 80. Patient can point out that on this spot, pain hochi. That means it is very rare or not possible. Heart attack hemti huve ni. Because it is a centralized pain. Heart attack is centralized pain. Patient cannot localize that pain is at here. No sir, kemti gote laguchi, bhitar kemti gote laguchi. But when patient localize that this is the pain, that means it is never be a myocardial infarction or anginal pain. So tenderness. बहुत टाइम रे ओपीडी देखु कोस्टोकॉन्ड्राइटिस मेनली लेडीज पेशेंट आसुचंदी यंग पेशेंट आसुचंदी सर एई पेनटा मते लागुची सो इट कैन द टेंडरनेस इज देयर आमे प्रेशराइज करले पेशेंट को पेन होची सो इट इज नेवर बी ए myocardial infarction or angina. The most important thing when a patient comes to us with a pleuritic pain माने प्लूरा जेतेबेले घसी होची दी पट दी टाको प्लूरा जेतेबेले घसी होची दैट पेन इज ए electric shock like pain and it is produced because of respiratory movement of chest wall. So it is a localized pain also. So these pain are not anginal pain. तो एटा तो गला chest discomfort. जेतेबेले पेशेंट रो डायबिटीज 30 years 20 years सेतेबेले डायबिटीज रे गोटे न्यूरोपैथी हुए नर्व डैमेज हुए सेतेबेले the person cannot perceive the pain as such. जेमती गोटे young patient perceive करिबो जेमती गोटे non diabetic patient perceive करिबो anginal pain टाकू गोटे long duration रो diabetic patient cannot perceive the pain as an anginal pain. He can perceive the pain like shortness of breath. टिके मते धइसई लागुची सर मते टिके nauseating लागुची vomiting लागुची and profuse sweating. बहुत टाइम रे पेशेंट सर मते टिके एमती पेन हला मुहर टिके झाळ बैला. No, it is not a MI diaphoresis. Diaphoresis means a drained sweats. पेशेंट पूरा ओद्दा हो सर एसी रे बसथिले गम गम हेकि झाळ बल्ला मोर पूरा गंजी पिन सब ओद्दा हो गला. So that diaphoresis is called drained diaphoresis and it is very characteristic of myocardial infarctions. So those patient in older age, those patient in ladies, those who are having diabetes for more than 20 to 30 years, they may not perceive the anginal pain like your chest discomfort. But in that situation, there is some shortness of breath, there is some nausea, vomiting, and mostly patient presented with diaphoresis. So these are called anginal equivalent. So they are not angina, but equivalent to angina because they are the diagnosis is myocardial infarctions. So in myocardial infarctions, there is chest discomfort that is called angina. Another is called non-angina or anginal equivalents like shortness of breath, like diaphoresis, nausea, vomiting. Many times patient presented with us with loss of consciousness in some MI context, like inferior MI. So we have to first clear about these things, angina, anginal equivalents, and those pain which is not characteristic of angina. So when patient comes to us with in emergency department, we have a very little time that we can diagnose a patient. So from the history, we have to first think the risk factors, what are the risk factors which are present in that patient. Now patient presented with like this angina. But ता पूर्वरु मु किछि chest discomfort बिचरे कहिबी. In coronary artery disease, there is a continuum. Coronary artery disease is because of obstruction in the coronaries. So there are two types of obstructions. First is atheromatous plaque obstruction. Second is the thrombus obstruction. So when atheromatous plaques are there, if this atheromatous plaque or the cholesterol deposition in your artery reduces the diameter of coronary artery more than 70%. More coronary रे जेति की diameter अच्छी तार 70% रू जेते बेले patient रो atheromatous plaque अधिका ही जाए, patient perceives angina on exertion. This is acute coronary syndrome. So the patient persists angina in rest. patient bosichi chest pain hoche. But when patient is having atheromatous plaque, more than 70% reduction of the radius of coronary artery, patient perceives angina, but during exercise. Mate chali ki gala balaku pain hochi, mate steps re chodhila balaku pain hochi. So that is called stable angina. The MI angina is unstable angina. Tar bhi difference achi. What is stable? Stable mane patient stable kotha kuha honi. The atheroma is stable. Atheroma upre gote plaque upre gote fibrin chador gote thai. So when that is stable, there is no excoriation, there is no fracture of that fibrin cap. The patient perceive angina during exercise. Kahinki? Because during exercise or during walking the staircases, heart rate is increasing. So the oxygen supply and demand mismatch is there. Mo oxygen जेतल heart rate बढ़ुची, मोर cardiac output बढ़ुची, सेतल मते oxygen आहुरी अधिका दरकार. Resting condition ने जेति थिला, oxygen nutrition मते अधिका दरकार during my exercise, कारण मोर cardiac output बढ़िलानी. But there is a plaque, blockage. So blood supply सेति की हेई पारुनी. तो इस्चिमिया हबो. तो ischemic pain आसीबो, patient टिके wait करिगला, टिके बसी गला, टिके भल लागिला, पुणी चलला. So this is because of stable atheroma in our coronary artery. Suppose को patient जमती precipitating factor या पूर्व slide रे कोहाला stress like hypertension accelerated हे गला से जो fibrin cap टा breach हे गला बाद टाणी की चिरी गला फाटी गला fissure हेला excoriate हेला. So that fibrin got exposed to the water column in coronary. So coagulation cascade will ensues. So coagulation cascade re first is platelet. ए बेसिक गुड़ा कौन पे दरकार बिकॉज आम लोडिंग डोज प्रेब्रिन दे दौचे आम एंटीकोआगुलेशन दे दौचे जी जोड़ा कर दौचे गोटे हो जाए बट व्हाई बिकॉज फास्ट द प्लेटलेट एग्रीगेशन डिपोजिशन है फास्ट तापर एग्रीगेट है आदेश नहीं की सो दैट लीड्स टू ए व्हाइट थ्रोम्बस नाउ द प्लेक इज अनस्टेबल सो नाउ द पेशेंट परसीव angina at rest कारण टोटल ब्लॉक हो 100% ब्लॉकेज हो कोरोनरी आर्टरी रो ना मते मु बसिकी भी मते पेन होउची एंड दैट पेन इज क्रेसेंडो मते बढ़ी 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 चलची बिकॉज नाउ देयर इज 100% कट ऑफ सो देयर इज नो ब्लड टू द कार्डियक टिश्यूज नो ऑक्सीजन नो न्यूट्रिशन बट स्टेबल एंजाइना रे कोन होतला मु बसिली मोर हार्ट रेट कमी गला कार्डियक आउटपुट कमी गला मोर डिमांड कमी गला तो मते भी कूल लागिला मु ठीक ठाक पुनी चलली. So this is the difference between stable angina and unstable angina or acute coronary syndrome. So when this type of patient, that means MI is an emergency, so it is called acute coronary syndrome. जोटा को stable angina 70% blockage था सेटा को कहते हैं chronic coronary syndrome or CCS or chronic stable angina CSA. All are CAD रो classifications. सो से पार्टा में डिस्कसन करूने एटा होची एक्यूट कोरोनरी सिंड्रोम जोटा कि आमे दीटा राति रे फेस करूचे पेशेंट को इन अनस्टेबल कंडीशन. सो व्हेन पेशेंट कम्स टू अस बेसिकली वी आर गो फॉर अ comorbidities like risk factors when patient is having diabetes hypertension and all hemodynamic केमती अछि complication कोन अछि because many times when patient comes to us they present with heart failure symptoms heart because of myocardial infarction the pumping of heart get reduced and patient goes or land up into pulmonary edema. So at that time, patient present to us with shortness of breath, which crackles all over our lungs field. So at that time, it is very important to stabilize first the patient, go through an ECG and diagnose a patient is having myocardial infarctions. So by the protocol, European society as well as American society, the first thing to do an electrocardiogram. मु भावुची प्राय पाखापाखि बहुत जगह ECG नाउ इट इज अवेलेबल सो विदिन 10 minutes ऑफ प्रेजेंटेशन पेशेंट आसबार 10 minute भितर जस्ट गो थ्रू एन ECG और इलेक्ट्रोकार्डियोग्राम इट इज बोथ डायग्नोसिस एज वेल एज प्रोग्नोसिस. डायग्नोसिस माने whether patient is having ST elevation or not, whether patient is having ST depression or not, whether patient is having T inversion or not. So that leads to ST elevated MI, non-ST elevated MI. So it is for diagnosis. Second is prognosis. What prognosis? suppose a patient comes to us with inferior wall MI, so that may lead to complete heart block, jota ki arrhythmia, bradyarrhythmia. Sometimes patient with ST elevated MI with ventricular tachycardia, ventricular fibrillation, so the prognosis is very bad in that situation. Patient death hovar chances within 1 hour is high. So when patient is having high ST elevation, bahut ST elevation achi, that means prognosis is bad. ST elevation means the myocardium get necrosed. Jette ST elevation hobo, the myocardium supplied through that coronary get damaged. Tanu that is having some prognosis. Now, when patient present to us with this anginal symptom, many times what will happen, ECG is normal. Jetol patient asila emergency ku ECG ame kale, ECG normal, but there is typical of symptoms. Angina achi, patient or risk factors achi. So don't biased with that normal ECG. Don't discharge that patient because of normal ECG. No. Many times the ECG findings at emergency is not there within 1 hour, 2 hour. So we have to do a serial ECG. 3 घंटा 4 घंटा पर मध्य हमें ECG रे ST elevation पाई पारिबा if the patient is having risk factors, if the patient is having typical of angina. So don't discharge the patient by seeing only that ECG is normal, patient रा heart attack नहीं, patient को घर को पठे देली पांट प्रजल दे कि patient तापरे लोक मानु धरी कि बाड़े पे आसीबो because patient brought dead. हम MI थिला हम diagnosis करि पारले नि गोटे ECG करि कि
Dr. Satpathy, we are sorry to interrupt. As we are already to our left, it is request from the chair that please conclude it in 5 to 7 minutes.
So we have to go for serial ECG. Now the biomarkers, if it is available, so go through troponin or CKMB. So when troponin is positive, ECG findings of ST elevation is there, and patient is having anginal pain, that means patient is having myocardial infarction or acute coronary syndrome. So if the initial set of markers is negative in patient who have presented within the first 6 hours of onset of pain, many times TROP-T is negative. So when patient is having TROP-T negative, just wait for another 3 to 4 hours because TROP-T will be positive even after 8 hours or 12 hours of symptoms. So just going through the basic of ST segment, it is the segment which represents at the end of S wave and the initiation of T wave. So that segment is ST. So with elevation, we can diagnose a patient is having ST elevation. So here some of the ST elevation are there. Now we can see that ST segment in this 5 ECG setup, it is more than 5 millimeters. So small box is 1 millimeter. So it is more than 5 millimeters. So already we have discussed that ACS, that means coronary artery disease, there is stable angina, unstable angina. So in acute coronary syndrome, it is 3 things, that is one is STEMI, if the patient is having ST elevations. If the patient is having ST depression, T inversion in ECG, that is N-STEMI, and if the patient is having ST elevation, ST depression or T inversion, but the biomarkers are negative, then it is called as a unstable angina. So already we have discussed this. So coming to the management. So when patient comes to us with this type of symptoms, ECG, in ECG we can diagnose patient is having ST elevated MI. The most important thing is revascularization. Ame coronary artery kholibar achi, so that blood can flow to the myocardium and we can salvage the myocardium. So time is the muscle. Jette sigra ame kariba ei jinsata ko sette sigra myocardium ta necrosis hobaru banchibo or irreversible damage hoba purpuru amku blood supply coronary artery re karibar achi. So in periphery, That means in PHC, CHC, where this type, or even in district headquarter hospital, when this angioplasty facilities are not possible, so in that situation, you have to breeze the therapy, ताकि patient symptomatically improve ही जाओ, किछि परिमाणर treatment पाई जाओ, ताकि से patient, we can shift that patient to tertiary care center or corporate center, जोठी के angiogram or angioplasty बा revascularization possible अच्छी. मु जिते रिसीव कली पेशेंट को जदि मु भाबुची जे मोर देन 2 hours लागिबो जदि सुंदरगढ़ रे मु पेशेंट को रिसीव कली एंड आई थिंक इफ आई transport the patient and it will take more than 2 hours to the tertiary care centers, so we have to go for the minimum treatment, that is loading dose and thrombolysis. Thrombolysis is the bridging therapy जोटा कि आमे पेशेंट को टिके डिले करि परिबा रिवास्कुलराइजेशन प्रॉपर करिया पाई कि. So when if the transportation time less than 120 minutes बा पेशेंट को पठेई हबो 2 घंटा भितरे, don't thrombolize the patient, just transport the patient to the tertiary care center, they will do the angiogram and angioplasty. If no, that means right side जदि आमे पठेई पारुने, it will take around more than 2 hours, 3 hours, 4 hours, so go for immediate fibrinolysis. जेतेबेले आमे पेशेंट emergency care रे रिसीव करछे, go through the loading dose. Loading means heavy dose of antiplatelet therapy. Why heavy dose? Because when ecosprin आमे जदि 75 milligram रे खाउचे, it will take some days to have a concentration that will reduce the platelet aggregation or adhesion. So it will take time. जते आमे loading dose दबा with high dose, it will take small time or it will take little time to inhibit the platelet. So that's why loading dose concept is there. तो आमे loading dose केते दिया हबो? Now the loading dose of antiplatelet, the aspirin. So most commonly giving drug is aspirin. Loading dose is 162 to 325 milligram. But एटा pharmacological आम इंडिया रे एई भला pharmacology dosing रे आसे नाही. तो आमे कोन करू 300 milligram रो इकोस्प्रिन पेशेंट को खाइबा को दो. खाइबा को माने चोबे की खाइबा को दो. जोटा कि आमे इकोस्प्रिन दउचे सेटा होची एंटेरिक कोटेड. माने सेटा स्टोमक थ्रू जाई कि एब्जॉर्प्शन हबो. मते बकाल म्यूकोस रे एब्जॉर्प्शन करियार अछि. तो आमे को चोबे की खाइबार अछि. सो 300 मिलीग्राम आमर इकोस्प्रिन आसुची 75 रे 150 रे आसुची. तेणु 150 रो 2टा टैबलेट नहिले इकोस्प्रिन रो 75 4टा टैबलेट. सो चुइंग टैबलेट दिया जाए. मेनी टाइम्स बेले बेले न थाए एंट्री कोटेड एस्पिरिन मध्ये आमे देई परिबा. So when the patient is having aspirin allergy or there is some bleeding tendency, we can go for a clopidogrel 300 milligram or 600 milligram. आमर जो यूजुअल आमे जति प्रोटोकॉल रखिछु जे इकोस्प्रिन बा एस्पिरिन हमको 300 मिलीग्राम प्लस क्लोपिडोग्रेल 300 मिलीग्राम एंड रोजुवास्टैटिन 40 मिलीग्राम और एटरवास्टैटिन 80 मिलीग्राम. 300 380 किंबा 300 340. This is the loading dose concept. तापरे पेशेंट को आमे शिफ्ट करू बा फिब्रिनोलाइसिस करिबा. सो लोडिंग डोज देला परे जो मती को हाला फिब्रिनोलाइसिस करिबा कि करिबानी. सो अगेन वी हैव टू थिंक फॉर दैट. नाउ पेशेंट कम्स टू अस इन इमरजेंसी डिपार्टमेंट देखिले सैचुरेशन लेस देन 90. सबु पेशेंट को ऑक्सीजन दबार कोनोसी जस्टिफिकेशन नाही, बिकॉज ऑक्सीजन कैन प्रोड्यूस रिएक्टिव ऑक्सीजन स्पेसीज और फ्री रेडिकल्स दैट मे लीड्स टू कोरोनरी स्पाजम. तेणु डिटोरेट करिबो. व्हेन पेशेंट इज हैविंग पल्मोनरी इडिमा, ता लंग्स जदि आमे प्रॉब्लम अछि क्रैकल्स देखिले एंड द सैचुरेशन इज लेस देन 90, देन वी कैन गो फॉर ऑक्सीजन थेरेपी. It is reasonable to administer supplemental oxygen to all patients with uncomplicated STEMI during first 6 hours. जदि आमे दबा को भी चाहिए 6 घंटा भीतर देई परिबा. But the class 1 indication if the saturation is less than 90. Patient को nitrate केते बेले दबा बा sorbitrate केते बेले दबा. When patient is having severe anginal pain, जते बेले patient को बहुत anginal pain होउची एवं blood pressure less than 90 नाही, सेते बेले आमे nitrate sublingual nitrate देई परिबा. So patient with ongoing ischemic discomfort should receive the sublingual nitroglycerin every 5 minutes for a total of 3 doses. So even after sublingual le bhi jodi patient ro chest discomfort no come hela, we can go for a IV nitroglycerin if it is available. So what is the contraindication? That nitrate should not be administered in patient with systolic blood pressure less than 90 millimeter or greater than or equal to 30 millimeter of mercury below the baseline. Patient ro jetiki BP thibo, suppose patient ro gote average 120 130 BP achi, now patient comes to us with 100 systolic, or patient is having less than 90 millimeter of mercury, don't go for nitrate, IV nitrate or sublingual nitrate. So for analgesia, the analgesia means the chest pain pain ki morphine is the analgesia of choice, but morphine is not available in periphery. So we can go for pethidine, 14 Phenergan, we can add to the patient. And coming to beta blockers, so beta blockers reduces the heart rate. So when patient is having a myocardial infarction in emergency department, we can go for a oral beta blocker therapy to reduce the oxygen demand and reduce the ischemic infarct of the heart. So for the fibrinolysis, just do 2-3 points. STEMI patient, the class 1 indication is STEMI patient presenting to a facilities without the capability for expert prompt interventions with primary PCI within 90 minutes of the first medical contact should undergo fibrinolysis unless contraindicated. Joti PCI hei pariboni, there is no ebong fibrinolysis ro contraindication nahi, seithi ame thrombolysis kari pariba. Ebe now it is free of cost, as madam said, in your district headquarter hospital also from So in the absence of contraindications, fibrinolytic therapy should be administered to STEMI patient with symptom onset within the prior 12 hours and ST elevation greater than 1 millimeter in at least 2 contiguous precordial leads. जदि पेशेंट 12 घंटा भितर आसीथिबो ताहले आमे थ्रोम्बोलिसिस करि परिबा. जदि थ्रोम्बोलिसिस मोर देन 12 आवर्स होची, वी शुड नॉट थ्रोम्बोलाइज द पेशेंट, just keep it in antiplatelet and anticoagulant therapy. So 2-3 points about contraindication of the fibrinolytic therapy. So first is previous intracranial hemorrhage. Jodi patient ro stroke achi, intracranial hemorrhage history achi, then we should not administer thrombolysis. Ischemic stroke within 6 months, any damage or neoplasm of CNS, jodi brain tumor achi kimba brain surgery heichi, so we should not go for thrombolytic therapy. Patient is having bleeding disorder, we should not go for a thrombolytic therapy. Some relative contraindication, the most important is hypertension. Jetale patient asuchanti more than 180 systolic blood pressure achi, just reduce the blood pressure by your nitroglycerin or some anti-analgesia. Then if it is less than 180, then go for a thrombolysis. So thrombolysis should not be there if it is more than 180 millimeter of mercury. So inter-hospital transfer for primary PCI, to achieve the optimal results, time from the first hospital door to balloon inflation in the second hospital. Mo pakhu jetale patient asuchi, that is the time, and mu पठौची गोटे टर्शियरी केयर सेंटर को सेठी प्राइमरी पीटीसी जेतले होउची से जो टाइम पीरियड टा शुड नॉट बी मोर देन 90 मिनिट्स, 1.5 घंटा भितर से जिनस हबार अछि. So significant reductions in door to balloon times might be achieved by directly transporting the patient to PCI centers rather than transporting them to the nearest hospital if the inter-hospital transfer will subsequently be required to obtain primary PCI. जदि मु गोटे पेशेंट को रिसीव करुच्ची मोर पीएचसी कि सीएससी रे लोडिंग डोज दौची, जदि मोर फिब्रिलोटिक थेरापी देई परिबी तो मु सेटिक भी देई दौची. जोटी फिब्रिलोटिक थेरापी देई हबनी पाखरे पीसीआई सेंटर अच्छी, सो डोंट थ्रोम्बोलाइज द पेशेंट एंड इमीडिएटली शिफ्ट द पेशेंट सो दैट द डोर टू बेलून टाइम मोर प्राइमरी पीटीसी पाई कि जेतले पेशेंट आसिला आपण पाखकु एवं प्राइमरी पीटीसी हबो, इट शुड बी विदिन द 90 मिनिट्स, 1.5 घंटा भितर हबा दरकार. बट इट इज वेरी चैलेंजिंग इन प्रैक्टिकल पॉइंट ऑफ व्यू. Thank you.
Thank you, Milan, for elaborating, starting from angina to pathophysiological process to manifestation and management in periphery center, including transport to the patient to the PCI center. And it is very applicable to each and every physician who are working in periphery as well as in tertiary health center also. Now it is open to, so because of constraints of time, we are not able to interacting more, but we would like to listen more frequently in near future. Anyway, thank you very, very much for your elaborate discussion.
Thank you, ma'am. Thank you. Thank you.
Dr. Satpathy, please wait. For felicitation.
Thank you, sir, for the wonderful talk about ACS. It will be really helpful for us in the periphery. I would request Dr. Chaitanya Maji sir to please come over to the stage and felicitate our speaker, Dr. Milan Satpathy sir. Thank you, sir. Now I would request Professor Dr. Malathi Madam to felicitate Dr. Hare Krishna, sir. Now I would request Dr. Dukhya Murmu, sir, to felicitate Dr. Prafulla Maji, sir. Thank you, sir. Now I would like to request Jatin Naik sir, DAMIT's director, to please come over to the stage. I request Dr. Hembram sir to please accompany sir to the stage.
Jotoko ke Johar. Very good morning. Abotalare net met Jatin Naik sir tiken ken setera kana. Nukin dukin hoyo kana director DAMITS jaha mitang noa abo tribal belt re mitang dominating men lekan hoyo dominating institution jaha re adik gyan gidra laboratory technicians course सहित पैरामेडिक कोर्सेस किन कराया ना साथ साथ अड़ी ज्ञान मैनेजमेंट कोर्स किन कराया और नुकिना द इंक्लाइनेशन टुवर्ड्स मयूरभंज चिका तो अकिन हो बेसिकली मयूरभंज सेट खनगे ओनाते तकिन अको इंक्लाइनेशन हो अब नोआ ऑर्गेनाइजेशन प्रति मेना चिकाते निया होला महंदर के टटका धरेगा जते बड़ा अब ट्रांसपोर्टेशन प्रॉब्लम एहब एना ओना जोखा लेनी उहेर के आज बांगा नुकिन हो बिटांग मेना किना जहां अब पलेट किन हेल्प बना अदो ओना हिसाब ते अलिंग अकलिनी अप्रोच करना अलिंग यार नुकिन डॉक्टर हेम्ब्रम सर तिकिन और अड़ी कुसी तेगे विदाउट एनी हेजिटेशन अब रेन नुको स्टूडेंट्स को ट्रांसपोर्टेशन बखरा किना ट्रांसपोर्टेशन सिस्टम जहां बसेस किन डिप्लॉय किया ओना लगी अड़ी अड़ी सरहाव और ओना सरहाव लगी के अलिंग डॉक्टर चैतन्य सर प्रेसिडेंट SDACON लिंग नेहर किना अकिन सर तिकिन किन फेलिसिटेट किना
Thank you very much. A very good afternoon to all of you. Myself, Dr. Jatin Naik, Chairman, Dr. Ambedkar Group of Institutions. I am from Mayurbhanj. I am passed out from this college, NIT Rourkela, in '86 in the branch of mechanical. So, since 36 years, I am in Rourkela. I am rendering several courses now. I am having 8 colleges in around Rourkela. And I feel proud to be amongst you today. That this conference is going on when Dr. Soren telephoned me that we are having a program in NIT on 27th and 28th. Please come. I expressed my inability because we are hosting and we are celebrating 25 years of Silver Jubilee in our college. Cabinet ministers and when VIPs are in our campus now. So still, because of his love and affection, I could not turn down his request. Now I have come over here to witness this function. And when I entered into this hall, my department, because I am a heart patient, something was discussion about that. So definitely this 2-day session might have encouraged and enriched the students for the medical services, and the society will be benefited much by this session. So I congratulate Dr. Soren and his team, and I request whenever you have such type of programs, my venue is already ready for you. I will give you my auditorium. May not be this big, but it is manageable. For Mayurbhanj, it is manageable. And I am there to receive with wholehearted support regarding transport and hall facility. Everything will be extended to all of you. So doctors are called the second God. So I convey my heartfelt thanks and regards to all of you. Thank you very much. Before I conclude, I want to also felicitate the program of this. Who is the president? I request President, please come to the dais. I want to present a bouquet to our President. He has selected Rourkela. He could have selected Mayurbhanj, Baripada, but he has selected.
This time we have the turn. This is the turn for the Rourkela.
Oh, this is the terms. Thank you. Thank you. Thank you very much, sir.
Yeah.
And I want to present a bouquet to our Soren sir, our immediate. This is not my. Thank you very much, Dr. Soren, for inviting me for this program. Once again, I pray the Almighty for your good health and good family, because you are the key persons to keep the society fit and fine. Thank you very much.
Thank you, sir, for your wonderful. Thank you, sir, for your wonderful words. Now I would request Mr. Kiran Kumar Kaura, sir, to please come over to the dais. He will be telling us today about saving versus investing, the big difference. And to chair the session, I would like to request Dr. Maisa Soren, sir, to please come over to the stage.
So good morning again. So I have a opportunity to introduce Mr. Kiran Kaura. Since we all are doctors, we are much worried about the health of the people. We are more concerned about the people day and night, but we forget ourselves how to care about our monetary systems, how to make good health of our money systems. For that, we are almost ignorant. Like, if I remember, all my doctor friends are also ignorant about their own health when they are much worried about their patient, but they forget about their own health. Similarly, also we may be earning a lot, but we are unable to manage our monetary systems. So for that, I'll request Mr. Kiran Kaura, who is from Mutual Fund organization, and he will be helping us how to manage our money and how to grow it without much stress. And I think this will be much benefited to all our doctor friends, because we all are earning, but we are unable to, we are, so to say, we are hand to mouth only. We are unable to contribute even to our society. But if we have an extra surplus, we can certainly extend our hand towards society to make it more healthier and wiser. Now, I request Kiran Karsar.
Thank you, sir. Hello. Thank you, sir. First of all, good evening, good morning to all, and doctors, and their family, and students. First of all, special thanks to Mr. Soren sir, Corneli Hembram sir, and Saurapani Hembram sir, giving me this kind of platform to represent regarding awareness of our financial product. First of all, I would like to introduce myself. My name is Kiran Kumarkar. I am having 15 years experience in banking. I was an ex-banker in Axis Bank, and I am localized near to Rourkela also. And 2019, I have started my own platform like Siddhi Financial Services, which I am dealing with mutual funds, tax planning, and bonds and stock also. आज के ज़माने में एक टॉपिक आ रहा है सेविंग्स एंड इन्वेस्टिंग। मैं सवाल पूछना चाहता हूँ, सेविंग और इन्वेस्टिंग, किनको पता है सेविंग्स क्या है, इन्वेस्टिंग क्या है? एनीबॉडी टेल व्हाट इज सेविंग एंड व्हाट इज इन्वेस्टिंग? ओके ओके राइट ओके हाँ, आई एम जस्ट गिविंग यू एग्जाम्पल ऑल्सो। सेविंग्स मतलब क्या होता है कि आप सपोज मान लीजिए एक मिडिल क्लास फैमिली 50,000 इनकम कर रहा है रेगुलर बेसिस में, 50,000 उसका मंथली सैलरी है। उसने क्या किया कि उसके बाद उसका कुछ एक्सपेंसेस रहता है, जैसे कि यहाँ पर बहुत सारा हाउस होल्ड है, हाउस वाइफ है कि वो लग जाकर सैलरी 50,000 दे दिए। डेली का खर्चा होता है, जैसे कि हम लोग का रेंट वगैरह हो गया, उस एक्सपेंस में जाता है। हम लोग का पेरेंट का हो गया, मेडिसिन हो गया, बच्चों का स्कूल फी हो गया, दीज आर द थिंग्स हम लोग का एक्सपेंस के अंदर आता है। उसके बाद क्या, हम लोग का कुछ लायबिलिटी भी रहता है, थोड़ा बहुत लायबिलिटी रहता है, जैसे कि हम लोग कार लोन हो गया, एजुकेशन लोन हो गया, दीज आर द लायबिलिटी। ये सब कट के हम लोग का एक्सपेंस और लायबिलिटी कट के जो बचता है वो हम लोग का सुख सेविंग्स रहता है। सेविंग्स को हम लोग क्या करते हैं, कोई भी हम लोग को कोई भी सवाल पूछता है, कोई भी चाय के टपरी में कोई भी सवाल पूछता है, भाई को इन्वेस्ट कर, हाँ मैं इन्वेस्ट कर रहा हूँ। सेविंग्स कहाँ होता है? बैंक अकाउंट में होता है। वो फिक्स डिपॉजिट बोलते हैं, जैसे कि हम लिक्विड टाइप बोलते हैं, फिक्स डिपॉजिट, जहाँ पर हम लोग का पैसा को इजीली वी कैन विड्रॉ द अमाउंट्स। जैसे कि एटीएम से हम निकाल सकते हैं, उसको यूज़ कर सकते हैं कहीं पर, शॉर्ट टर्म गोल जिसको बोलते हैं, शॉर्ट टर्म गोल के लिए हम लोग यूज़ कर सकते हैं अमाउंट को। तो जब हम लोग सेविंग्स के बारे में जाते हैं एक्चुअली, तो जब हम सेविंग्स के बारे में होते हैं, हम लोग सेविंग्स का प्रोडक्ट, जो सेविंग्स का प्रोडक्ट क्या क्या रहता है, मैं वही सवाल पूछना चाहता हूँ। आप लोग सेविंग्स का प्रोडक्ट में कौन कौन सा चीज आता है एक्चुअली? हम लोग थोड़ा बहुत करते हैं। जो चीज़ हम एफडी, नॉर्मली क्या होता है कि हम लोग का जो जमाना है अभी बैंकिंग सेक्टर में, हम लोग ट्रेडिशनल वे में जा रहे हैं। यू आर गोइंग विद ट्रेडिशनल, क्योंकि पहला चीज़ सेविंग्स, इन्वेस्टिंग से पहला इंपॉर्टेंट चीज़ होता है हम लोग का सेविंग्स, आफ्टर दैट इन्वेस्टिंग। पहले हमको सेव करेंगे तो इन्वेस्ट करेंगे ना। जब तक हम सेविंग्स नहीं कराएंगे तो हम लोग इन्वेस्टमेंट में कैसे जाएंगे आप लोग धीरे धीरे से। पहले हम लोग को सेविंग्स करना पड़ेगा। सेविंग्स के लिए मैं जो आपको पूछा है, कुछ इनकम बचा के रखना जो शॉर्ट टर्म गोल के लिए। आफ्टर शॉर्ट टर्म गोल वी आर गोइंग फॉर लॉन्ग टर्म असेट्स। क्योंकि सार हम लोग को बोले कि एफडी, फिक्स डिपॉजिट एंड हो गया हम लोग का थोड़ा बहुत अभी सेविंग्स के लिए हम लोग गोल्ड सिल्वर ले सकते हैं। कोई कोई उसको इन्वेस्टिंग हिसाब से लेता है, बट गोल्ड एंड सिल्वर जो हम लोग का कमोडिटी एसेट्स बोलते हैं, वो एक इमोशनल एसेट्स हो गया। इट नॉट लाइक इन्वेस्टमेंट एसेट्स, इट्स इमोशनल अटैचमेंट एसेट्स। और एक चीज़ हमें बताना चाहता हूँ, एफडी और हम लोग का जो आरडी में एक फ़र्क होता है कि हम लोग उसको टैक्सेशन के बारे में डिस्कशन करेंगे। और एक चीज़ होता है इन्फ्लेशन। हम बता सकते हैं अभी महंगाई कितना चल रहा है? महंगाई ज़्यादा हो रहा है। एवरी ईयर्स महंगाई 5 to 6% ग्रोथ हो रहा है। फिर भी हम बैंक जब जाते हैं, भाई नहीं मेरे को बच्चे का चाइल्ड के लिए रखना है, पेरेंट्स के कोई मेडिकल एक्सपेंस के लिए रखना है, फ्यूचर के लिए, तो मेरे को सेविंग करना है। पर तो हम लोग क्या करते हैं, बैंकिंग सेक्टर में जब था कि सर एफडी कर दीजिए, वो आप सोच रहे हैं वो एफडी 2-3 साल के बाद हम लोग का जो लॉन्ग टर्म गोल होता है वो क्या मीट कर पाएगा? फिक्स डिपॉजिट जो रहता है, कोई जो हम लोग बचाते हैं, जो सेविंग्स करते हैं, सेविंग्स को हम इन्वेस्टमेंट जब जाते हैं हम लोग चूज करते हैं फिक्स डिपॉजिट। बट फिक्स डिपॉजिट इट इज सिक्योर एसेट्स। लास्ट में मैं बताऊंगा आपको वो कि आप लोग का लॉन्ग टर्म जो गोल है, वो गोल को हम लोग बचा सकता है, वो नहीं बचा पाएगा। तो हम लोग डिफरेंट इंस्ट्रूमेंट यूज करते हैं। क्या क्या इंस्ट्रूमेंट आजकल यूज करते हैं सबको पता है, क्यों? सबके पास यूट्यूब है। म्यूचुअल फंड्स हो गया, स्टॉक्स हो गया, बॉन्ड्स हो गया, रियल एस्टेट हो गया, ये सारा चीज हम लोग यूज करते हैं फॉर हम लोग लॉन्ग टर्म एसेट्स के लिए, कि हम लोग कुछ कर पाएंगे, हम लोग कुछ घर बना पाएंगे, रियल एस्टेट में कुछ लगा पाएंगे, बेटी का शादी, बेटा का शादी कर पाएंगे। दीज आर द रेगुलर थिंकिंग वी आर ऑलवेज बी डिस्कसिंग विद आवर फ्रेंड्स एंड फैमिली ऑल्सो, कि बच्चा का शादी के लिए मेरे को कुछ रखना है। जब रखने के बाद आते हैं हम लोग क्या करते हैं, नॉर्मली सेविंग्स एक ट्रेडिशनल वे में जाते हैं। बट इंडिया में क्या होता है हम लोग का अभी, कि हम लोग का एक जो चीज़ होता है इन्फ्लेशन, जो महंगाई होता है क्या कि धीरे धीरे से वो खा लेता है हम लोग का सेविंग्स का अमाउंट को। महंगाई 6-7% हो रहा है, 5-6% हो रहा है, तो फ्लक्चुएशन हो रहा है। उसी हिसाब में बैंक का जो हम लोग का ट्रेडिशनल सेविंग रेट ऑफ इंटरेस्ट वो नहीं बढ़ रहा है, वो इनकम के हिसाब से हम लोग को धीरे धीरे कम होते जा रहा है। तो मैं अभी आपको बताया हूं कि हम लोग इंडियन हाउस होल्ड ऑलवेज लुकिंग फॉर द सेफेस्ट एसेट। सेफेस्ट एसेट क्या होता है, हम लोग एफडी एंड आरडी जो हम लोग उसके ये करते हैं। और मैं बताई हूं आपको अभी रिसेंटली कि इन्फ्लेशन, जो इन्फ्लेशन होता है, जो महंगाई, हम लोग का लैंग्वेज बोलते महंगाई, जो महंगाई क्या होता है हर साल बढ़ता जा रहा है, हर साल। मैं नहीं बोल रहा हूं कि इंडिया में महंगाई अभी, बट अभी देखने से हम लोग यूएसए में हम लोग का जो फाइनेंशियल लिटरेसी मार्केट अभी 100 साल हो गया। हम लोग तो ज़्यादा नहीं, हम 30-35 साल में अभी तक हैं। अभी हम लोग का 7-8 साल हुआ है, महंगाई का भाव धीरे धीरे बढ़ रहा है। एक्चुअली जो चीज़ है इन्फ्लेशन, जो इन्फ्लेशन क्या करता है, हम लोग को मेन चीज़ को खा लेता है धीरे धीरे से। फिक्स डिपॉजिट एंड म्यूचुअल फंड। मैं अभी एक सवाल पूछना चाहता हूँ। म्यूचुअल फंड एक चीज़ होता है कि हर चीज़ जब मोबाइल खोलते हैं आप लोगों को कोई ना कोई भी रिपोर्ट आता है, यूट्यूबर वाला बोलते हैं म्यूचुअल फंड्स, स्टॉक्स, बॉन्ड्स, कॉर्पोरेट बॉन्ड्स, डिफरेंट थिंग्स वो लोग बोलते हैं। तो मेरे को सवाल है कि एक्चुअली म्यूचुअल फंड होता क्या है? कोई बता सकता है म्यूचुअल फंड होता क्या है? हर कोई बोलता है म्यूचुअल फंड्स करो, SIP करो, RD करो, FD करो। म्यूचुअल फंड होता क्या है?
इन्फ्लेशन जो है
सर सही कुछ बोले, तो उसमें कुछ मैं ऐड करना चाहता हूँ। म्यूचुअल फंड एक सौ तो पूल ऑफ फंड्स रहता है, जैसे कि आपका पैसा, आपका कुछ लॉन्ग टर्म गोल रहता है, सर का पैसा, सबका 10-15 का सर का पैसा एक तो फंड में डाला जाता है। कोई भी अगर फंड सर जो बोले लार्ज कैप मैंने कुछ कंपनी में लगा जाता है, जैसे कि हम लोग रेगुलर जो वो कंपनी यूज़ कर रहे हैं, जैसे बहुत सारे कंपनी बैंकिंग सेक्टर हो गया, तो मान लीजिए 100 कंपनी में लगा जाता है। 100 कंपनी में आपका पैसा जो भी है अमाउंट हम लगा, उसको म्यूचुअल फंड बोलते हैं। देखिए 50,000 हो गया, 1 लाख हो गया, उसको म्यूचुअल फंड। बट म्यूचुअल फंड क्या होता है कि ओनली फॉर लॉन्ग टर्म गोल, नॉट फॉर शॉर्ट टर्म असेट्स। ये लॉन्ग टर्म के लिए म्यूचुअल फंड सही है। जैसे कि हम लोग अभी अवेयरनेस चल रहा था आपका रथ यात्रा टाइम में, म्यूचुअल फंड सही है बोल के। म्यूचुअल फंड सही क्या होता है कि लॉन्ग टर्म एसेट के लिए बहुत ही जरूरी है हम लोग का रिक्वायरमेंट का फुलफिल करने के लिए। तो ये क्या होता है हम लोग का जो म्यूचुअल फंड होता है हम लोग का, कि ये रिटर्न जब देखते हैं वो फिक्स रहता है। मैं पहले बोल दिया कि रिटर्न फिक्स रहेगा, 6%, 7%, इट विल बी फिक्स्ड। बट म्यूचुअल फंड जो होता है मार्केट के हिसाब से वो रिटर्न देता है। आपको गोल सेट करना है कि मार्केट के हिसाब, आपको टाइम कितना पड़ेगा, मार्केट के हिसाब से आपको देना पड़ेगा कि नहीं, हम लोग का मार्केट लिंक रहता है। रिटर्न विजिबिलिटी मतलब क्या होता है कि हम लोग को मैंने हम लोग लिखा जाता है, हम लोग को फिक्स डिपॉजिट बॉन्ड दिया जाता है कि नहीं भाई तेरे को, हम लोग को आपको 6% मिलेगा, 6% कि 5% जो भी है बैंक का जो रेट ऑफ इंटरेस्ट है वो आपको मिलेगा, 5, 6, 4 जो भी परसेंटेज आपको मिलेगा। बट म्यूचुअल फंड्स क्या होता है कि ऑर्डिनर विजिबल, वो इंटरेस्ट पता नहीं चलता है। इस डिपेंड्स ऑन द कंपनी ग्रोथ। जो कंपनी में हम लगाते हैं, कंपनी का बैंकिंग सेक्टर हो गया, जो बैंकिंग में पैसा जा रहा है, आपका हो गया फार्मा सेक्टर हो गया, इस सेक्टर में हम लगाना है पैसा, वो सेक्टर का जो ग्रोथ रहेगा उसी हिसाब के आपका स्कीम का भी ग्रोथ रहता है। कंपाउंडिंग क्या होता है कि लिमिटेड रहता है उसका। मैंने आपको मान लीजिए कोई एफडी कर रहा है, उसका MIS ले ले, मंथली इंटरेस्ट स्कीम में जा रहा है, उसको जो इंटरेस्ट मंथली लेगा वो सिंपल के हिसाब से सिंपल इंटरेस्ट में जाएगा। और इसमें कंपाउंडिंग जो होता है हम लोग उड़िया में चक्रवृद्धि सूद लिमिटेड रहेगा। बट इन केस ऑफ म्यूचुअल फंड्स वो क्या होता है कि आप लोगों का कंपाउंडिंग के हिसाब से जाता है, मैंने कंपाउंडिंग होता है, मैंने इंटरेस्ट के ऊपर इंटरेस्ट आपको मिलता जाता है। बट इट डिपेंड्स ऑन द मार्केट सिचुएशन एंड योर लॉन्ग टर्म टारगेट, लॉन्ग टर्म एसेट्स। और इसमें हम लोग का इन्फ्लेशन, जो महंगाई एडजस्टमेंट नहीं करेगा, उसका कैलकुलेशन नेक्स्ट स्लाइड में बताऊंगा, जो इन्फ्लेशन कैसे कैलकुलेशन होता है हम लोग का। और इसमें ये इन्फ्लेशन को बीट करता है, फाइट करता है इन्फ्लेशन में, इसलिए हम लोग म्यूचुअल फंड को चूज करते हैं लॉन्ग टर्म एसेट के लिए। वेल्थ ऑब्जेक्टिव, ये क्या होता है, आप लोग जो 5 लाख दिए हैं फिक्स डिपॉजिट में लिखा है नहीं तेरे आपको मिलेगा आफ्टर 1 ईयर 5,30,000, मतलब 30,000 ही आपको मिलेगा कि 2 ईयर्स में आपको 70,000 या जो भी अमाउंट है वो मिलेगा। बट आपका इन केस बट इसमें कैपिटल का प्रोटेक्शन रहता है, मैं बोला कि पूरा प्योरली आपको सिक्योर्ड रहता है ये। बट म्यूचुअल फंड जो 2 चीज़ रहता है, इक्विटी फंड जो भी है वो रहता है कैपिटल एप्रिसिएशन, जो भी पैसा आपको पड़ा रहेगा वो आज नहीं तो कल बढ़ेगा, वो एप्रिसिएशन होके जाएगा, आज नहीं बढ़ा तो 2 साल के 3 साल में बढ़ते जाएगा वो। इसे लॉन्ग टर्म थिंकिंग गोल म्यूचुअल फंड्स। ये होता है सर आपका स्कीम है, एक इक्विटी एंड हाइब्रिड होता है, डेब्ट स्कीम जो गवर्नमेंट का पेपर में इन्वेस्ट होता है, जैसे बैलेंस एडवांटेज फंड गवर्नमेंट स्कीम में चला, गवर्नमेंट सिक्योरिटी में इन्वेस्ट होता है आपका। डेट इंस्ट्रूमेंट जितना भी है गवर्नमेंट का, सर्टिफिकेट ऑफ डिपॉजिट, कमर्शियल पेपर, जो गवर्नमेंट का जितना भी डिपॉजिट है उसमें इन्वेस्ट रहता है वो डेब्ट फंड। उसको बोलते हैं ऑल्टरनेटिव ऑफ द एफडी। एवरेज ग्रोथ रिटर्न नॉर्मली मैं इस तरह जस्ट ये एग्जांपल रखा हूँ, इसमें मैंने ग्रोथ रिटर्न 6-7% एफडी का रहता है और म्यूचुअल फंड का 10 to 12%, 14% आसपास एज पर द मार्केट के हिसाब से रिटर्न देता है। इन्फ्लेशन जो भी है आपका 6%, इसमें भी काम करेगा। इंडियन में 6% का एक एवरेज रेट ऑफ लिया है, बट रियल रिटर्न वो फाइट करता है आपका इन्फ्लेशन का 4 to 8%, क्योंकि एफडी क्या करेगा, आपको मनी को प्रोटेक्ट करेगा। म्यूचुअल फंड जो मनी रहेगा वो एप्रिसिएट करेगा, आपको ग्रो करेगा आपको आफ्टर बीटिंग द इन्फ्लेशन, महंगाई को। बट एक सवाल, सब्जेक्ट टू योर गोल, आपका गोल क्या है, आपका लॉन्ग टर्म विजन है या शॉर्ट टर्म विजन है। सब्जेक्ट टू गोल के हिसाब से हम लोग म्यूचुअल फंड्स में इन्वेस्ट करते हैं। तो अभी क्या है ना, टैक्सेशन का मैं पार्ट बोल रहा हूँ। टैक्स का अभी बहुत सारा ही चलता है एक्चुअली हम लोग का। पहले जो इन्वेस्ट होता है, हम लोग सब कोई सवाल पूछते हैं, सर टैक्स कितना लगेगा, गवर्नमेंट कितना लेगा। हर कोई का मुद्दा होता है गवर्नमेंट। इस पर तो स्लैब के हिसाब से सब कोई, जितना भी डॉक्टर है सब कोई 30% स्लैब में ही आते हैं। कोई आपका कोई 10 या 5, 10, 20% स्लैब में कोई भी नहीं है, सब 30% स्लैब में आता है एक्चुअली। ये क्या कहता है, आपका एवरी ईयर आपको टैक्स पेमेंट होता है। इसका सवाल है, फिक्स्ड डिपॉजिट आप बोल रहे हैं कि मैं एफडी किया हूं, बट हर साल का जो इंटरेस्ट होता है उसको बोलते हैं इक्विटी इंटरेस्ट, में टैक्स पेमेंट हो रहा है आपका। हर साल आपको टैक्स पेमेंट करना पड़ेगा एफडी के ऊपर, जितना भी एज पर द स्लैब के हिसाब से जो कैलकुलेशन होता है। बट म्यूचुअल फंड में क्या होता है कि जब आप रिडम्पशन करेंगे, सब्जेक्ट योर अचीविंग योर गोल, आपका गोल अचीव होने के बाद, आपका जो गोल सेटिंग किए हैं आप, जितना फाइनेंशियल प्लानिंग के लिए गोल सेटिंग किए हैं, अचीव होने के बाद आप विड्रॉ करेंगे, उस टाइम आपको जितना पड़ेगा लॉन्ग टर्म कैपिटल गेन टैक्स जो है आपका 12.5 अभी का जो गवर्नमेंट सेट किया उतना पड़ेगा। 30% टोटल 30%। उसका स्लैब जो होता है, मैंने म्यूचुअल फंड्स में कितना इनकम है उस हिसाब से 12.5, 30% स्लैब में वो नहीं आएगा। और ये कंपाउंडिंग तर हर साल का रहता है, चक्रवृद्धि कंपाउंडिंग हर साल धीरे धीरे जाता है। ये होता है म्यूचुअल फंड्स और इसका एफडी का। फिक्स डिपॉजिट जब हम लोग करते हैं, एक तो हम लोग टीडीएस भरते हैं, ये अलग से 10%, जो 10,000 के ऊपर रहता है, टैक्स डिडक्टेड सोर्स बोलते हैं। उसके बाद ही हम लोग भी फिर भी देते हैं, जो इनकम जनरेट होता है उसके बाद भी हम लोग टैक्स भरते हैं। टैक्स देने के बाद जो इनकम जनरेट हुआ ना हर साल का, भाई इंटरेस्ट में टैक्स तो टीडीएस कट गया, उसके बाद भी तो हमको इनकम शो करना पड़ेगा, भाई मैं इतना इनकम किया, उसके ऊपर भी टैक्स में डबल टैक्स के हिसाब से कैलकुलेशन होता है। वो इफेक्टिव आपका रिटर्न होने के बाद आपका रिटर्न हर 4-5% में आता है, क्योंकि सारा इतना पैसा आने से भी अभी का जो महंगाई है 7-6% वो खा जाएगा। कि हम लोग सोचते हैं कि नहीं, मैं बेटी के लिए मैरिज के लिए रखा हूँ तो मैं 5 साल के 4 साल के बाद निकलेगा, बट 5 साल 6 साल के बाद अभी का जो जितना रेट है कोई भी चीज़ का, उस टाइम रेट हाई भी होगा। वो क्या आपका मैरिज के टाइम में वो एफडी का रिटर्न बीट करेगा? कभी भी नहीं करेगा। वही सेम आपको कैपिटल को तोड़ के आपको जमा करना पड़ेगा शादी के लिए। ये है आपका इक्विटी म्यूचुअल फंड्स, जो हम लोग सारे भी पूछेंगे टैक्स कितने लगेगा। ये होता है, मान लीजिए मैं एग्जांपल दे रहा हूँ कि आप लोगों 10 लाख का इन्वेस्टमेंट किए हैं, मान लीजिए 1 साल के बाद वो 12 लाख हुआ, तो आपका 1,25,000 उसमें से माइनस होने के बाद 75,000 के ऊपर से आपको 12% का टैक्स लग गया उसका। वो ऑटोमेटिकली आपका जो कैलकुलेटर होता है इनकम टैक्स कैलकुलेटर से, ऑटोमेटिक सिस्टम आजकल सिस्टम जनरेटेड हुए वो ले जाएगा। और डेट म्यूचुअल फंड होता है जो सेफ एंड सिक्योर इन्वेस्टमेंट, जो एफडी फिक्स डिपॉजिट से थोड़ा 2-3% ज़्यादा होता है। जैसे कि थोड़ा बहुत फंड होता है, बैलेंस फंड आप सुने होंगे, बैलेंस एडवांटेज फंड रहता है, दो डेप्ट टाइप का रहता है, उसमें मार्केट लिंक थोड़ा कम रहता है, ज़्यादा इतना नहीं रहता है। ये जस्ट एग्जाम्पल दिया हूँ मैं, जस्ट फॉर द सेक ऑफ प्रेजेंट सिनेरियो एक एग्जाम्पल के लिए है। तो इसमें से मैं लिखा हूँ एक ने किया आपका एफडी फिक्स डिपॉजिट का 10 लाख का 10 ईयर्स के लिए फिक्स डिपॉजिट हुआ, तो मैच्योरिटी वैल्यू आफ्टर 10 ईयर्स, बट एफडी का रेट ऑफ इंटरेस्ट में लिख दिया हूँ 6.5 एच पर 10 लाख, बट हम लोग को टोटल आपका मैच्योरिटी आया 10 साल के बाद 18.7 लाख। ठीक है, आप लोगों का इंटरेस्ट अर्न हो रहा है 8,70,000, याद रखिए इतना इंटरेस्ट। 30% स्लैब सबका ही होता है आजकल जब, तो उसमें से आपका 2,60,000 का टैक्स कट गया, तो आपके खाता में आएगा आपका 16,01,000, ये फिक्स डिपॉजिट का। जब म्यूचुअल फंड का बारी आता है तो हम लोग क्या करते हैं कि 10 साल का सब्जेक्ट, जब हम म्यूचुअल फंड डिसाइड किए मेरे को 10 ईयर्स करना है, मैं गोल सेटिंग के लिए आपको बोला हूँ, आपको गोल सेट करना है कि आप लोग कितना साल रखना है। आपको गोल सेटिंग में ये सब चीज़ रहेगा कि हम लिक्विड में कितना रखना है, लिक्विड में एफडी भी आता है, ठीक है, और मेरे को लॉन्ग टर्म में कितना रखना है। तो उसी हिसाब पोर्टफोलियो के हिसाब से कैलकुलेशन हुआ है 12% के हिसाब से 10 लाख का आपका पाखा भी मैच्योरिटी अमाउंट 31 लाख इन्वेस्ट हुआ है 12% कैलकुलेशन के हिसाब से। 12% कैलकुलेशन जो स्कीम हम लोग आपको दिए हैं, जो फंड हम लोग चॉइस करके दिए, उसमें से हम 21 लाख का नेट प्रॉफिट हुआ है, उसमें से हुआ था आपका प्रॉफिट हुआ था 8 लाख, इसमें 21 लाख का प्रॉफिट हुआ है। लॉन्ग टर्म कैपिटल गेन टैक्स 12.5 जो है, उसमें से आपका 2.48 लाख आपका कट गया, आपके खाता में आएगा 28,61,000। मतलब फिक्स डिपॉजिट से म्यूचुअल फंड 10 ईयर्स सब्जेक्ट टू आपका गोल सेटिंग क्या है, आपका फाइनेंशियल गोल क्या है, आपका रिक्वायरमेंट क्या है, उसी हिसाब का कैलकुलेशन बनाए हो मैंने इसको। एफडी से आपको ज़्यादा 12,50,000 आपको मिला फिक्स डिपॉजिट से। जब एसआईपी एक चीज़ होता है हम लोग का, आरडी कोई भी पुराना जमाने जाएंगे, अभी भी मैं पोस्ट ऑफिस जाता हूँ कुछ काम के लिए, कि मैं देखता हूँ कि लाइन पूरा जमा रहता है धाड़ी में, कोई भी काम, क्योंकि मेरा फैमिली मैंने मेरा टोटल फैमिली पोस्टल में है, राउरकेला में बहुत है, मेरा फैमिली टोटल पोस्टल में है। जब भी मैं कुछ काम के लिए पोस्ट ऑफिस जाता हूँ, अभी भी हम लोग का ट्रेडिशनल वे में अभी भी पोस्टल में लाइन लंबे रहते हैं कि 5,000, 6,000, 7,000 के आरडी कर, भाई मैं आरडी बना रहा हूँ बैंक में। ये रिकरिंग डिपॉजिट एंड एसआईपी, ठीक है, जो सिस्टमेटिक इन्वेस्टमेंट प्लान, दूसरे वर्ड में बोल सकता हूँ स्लीप इन पीस भी बोल सकते हैं उसको, ठीक है। उस टाइम का जो आपका मार्केट का जो रिटर्न ग्रोथ होगा उस हिसाब से मिलेगा आपको, चाहे वो डाउन हो चाहे वो, मैं इसलिए आपको मार्केट लिंक बोल दिया आपको। रुपी कॉस्ट एवरेजिंग जो हम लोग का कंपाउंडिंग बोलते हैं, वो आरडी में नहीं होता है, बट इसका जो वेल्थ क्रिएशन रहता है आरडी का, कंजर्वेटिव या लोअर पोटेंशियल आपका रहता है। और एसआईपी क्या होता है कि आपका कोई भी एसआईपी करने के लिए जाएंगे तो ये आपका डीप में डिसाइड करना पड़ेगी। किरण जी, मैं एक एसआईपी करना चाहता हूँ, बट आपको एक अच्छा स्कीम देना पड़ेगा जिसका प्राइस, जिसका वैल्यू थोड़ा कम होना चाहिए। और अभी का सिचुएशन में हम लोगों को कहाँ इन्वेस्ट करना है, एक्चुअली आप बेटर इसके लिए फाइनेंशियल आइडिया दे सकते हैं कि हम लोग इसमें इन्वेस्ट करने से हम लोगों को, मैं उस टाइम 50 कितना साल के लिए वो बाई ऑन डीप स्ट्रेटेजी उसमें यूज होता है कि नहीं सर ये हर महीना का इतना प्राइस में जाएगा, इसका एनालिसिस वही है। और हायर ग्रोथ ट्रेजेक्टरी रहता है, 5 साल एसआईपी, 3 साल, 5 साल, 7 साल, 10 साल रखने से उसका कंपाउंडिंग से अच्छा रिटर्न मिलता है एसआईपी में। ऑलरेडी मैं ये सब टैक्स के बारे में दिया हूँ। एसआईपी जो चीज़ होता है आप जब निकालते हैं, वो आरडी का क्या होता है, आरडी में क्या होता है आपको हर साल का आपको टैक्स लग जाएगा, जैसे एफडी में लगता है। आप आरडी कर रहे हैं, आप विड्रॉ नहीं कर रहे हैं, पर हर साल आपको टैक्स देना पड़ेगा, जो भी इंटरेस्ट, एक्विट इंटरेस्ट, उसका जो एक्विट इंटरेस्ट जनरेट होगा, जैसे कि हम इनकम टैक्स के साइड में हम चेक करते हैं, हम एनुअल इन्फॉर्मेशन सिस्टम जो जाता है उसमें भाई मैं आरडी किया हूँ इस पर टैक्स करूँ, बट उस टाइम आपका एसआईपी और म्यूचुअल फंड आपका शो नहीं करेगा जब तक आप उसको विड्रॉ नहीं करते। एक्चुअली इसमें लिख दिया ओनली कैपिटल गेन टैक्स एट द विड्रॉल एसआईपी, एंड एसआईपी में आपका एनुअल टैक्स ट्रैक एंटायर अमाउंट कंपाउंडिंग ऑन टैक्स, उसका जो कैपिटल गेन टैक्स रहेगा। ये आरडी का है, जस्ट एग्जांपल ऑफ फॉर 10,000 का दिया हूँ, 20 ईयर्स के लिए किया है एसआईपी। एसआईपी में क्या होता है कि आप डिफरेंट प्राइस, आरडी से मंथली कटता है ना, वो डिफरेंट प्राइस लेंगे, हर महीना का कुछ डिफरेंट दाम में आप परचेज करेंगे, और जो फिक्स डिपॉजिट आप वन टाइम के लिए बोला एक ही प्राइस में आपको परचेज किया, तो उसमें से आपको टोटल इन्वेस्टमेंट हो रहा है 24 लाख का। मैच्योरिटी वैल्यू आपका आ रहा है आपका 46 लाख आरडी में, जो कि आपका टैक्स आप दे रहे हैं 20 ईयर्स में 6.5 लाख, और आपका खाता में आ रहा है ओनली 40 लाख के आसपास आ रहा है। सेम चीज आपका गोल सेटिंग करके डिफरेंट स्कीम में डाल के आपका एसआईपी हम लोग कर रहे हैं 10,000 का 20 ईयर्स, मैंने आफ्टर आपका सेविंग होने के बाद कुछ पैसा बचता है तो उसमें पोर्टफोलियो वैल्यू आपका बन रहा है, टोटल जो बोल रहे हैं जो इन्वेस्टमेंट किया है 24 लाख, और मार्केट वैल्यू बन रहा है आपका 1 करोड़। आपका 20 ईयर्स का मैं ले रहा हूँ, 20 ईयर्स से स्लैब में देखेंगे तो कैपिटल गेन हो गया आपका, प्रॉफिट हुआ है आपका 74 लाख का, और टैक्स उसमें से दे रहा है 9 लाख। 1 करोड़ पोर्टफोलियो बना, 9 लाख का टैक्स बना, और आपका टोटल पोस्ट टैक्स वैल्यू आ गया 90 लाख। ये डिपेंड करता है जब आप प्लानिंग करते हैं, आपका गोल सेटिंग करते हैं, कौन सा स्कीम, कौन सा मैंने सेक्टर में, कौन सा डिपार्टमेंट में हमको इन्वेस्ट करना है एक्चुअली। जैसे कि कोई भी बैंक में जाते हैं, पहले आप गोल बोलते हैं, उसी हिसाब से आप प्लानिंग होता है एक्चुअली, आपका गोल क्या है। बिहेवियरल ऑफ एडवांटेज ऑफ एसआईपी, ये क्या होता है, आपका रिस्क को मिनिमाइज करता है, वन टाइम एक प्राइस में करता है, रिस्क थोड़ा मिनिमाइज होता है जो मैं कंपाउंडिंग बताया, और ये है लॉन्ग टर्म डिसिप्लिन के लिए आपको ग्रोथ देता है। कोई भी एसआईपी, बहुत सारे एसआईपी इज ए नाइस प्लेटफॉर्म, नाइस वे टू इन्वेस्ट योर मनी टू जनरेट योर इनकम। जो जितने अभी स्टूडेंट लोग हैं, जब अभी उनके एज के हिसाब से उनको ये सब एसआईपी स्टार्ट करने से उनके लिए फ्यूचर के लिए ग्रोथ हो सकता है। एसआईपी एनी अमाउंट, नॉट लाइक दैट कि आप 5,000 कीजिए, 1,000 भी कर सकते, 100 भी कर सकते, 500 भी कर सकते हैं एसआईपी का। ये प्रोडक्ट सुटेबल मैट्रिक्स होता है हम लोग का। जो एफडी जो मैं पहले बोल दिया था आपको कि फिक्स डिपॉजिट हम इमरजेंसी फंड के लिए रखते हैं। इमरजेंसी फंड मतलब कि 6 महीना 7 महीने के लिए मेरे को कोई मेडिकल का इमरजेंसी है, मेरे को इतना मेडिकल का इमरजेंसी चाहिए, फिक्स डिपॉजिट, और क्योंकि इसमें लिक्विडिटी रहता है। और फिक्स डिपॉजिट में, इमरजेंसी फंड में, म्यूचुअल फंड में एक चीज़ होता है, उसको बोलते हैं लिक्विड फंड्स। लिक्विड फंड भी इज ए वन टाइप ऑफ आपका इमरजेंसी फंड के लिए यूज होता है, इसमें लिखा नहीं, बट लिक्विड फंड जो होता है इमरजेंसी फंड में रखा जाता है एक्चुअली। और शॉर्ट टर्म गोल के लिए आपका जो है फिक्स डिपॉजिट बिलो 3 ईयर्स, ये 6 महीना 1 साल, कोई 2 साल भी एफडी करते हैं। बट लॉन्ग टर्म गोल के लिए आपका एसआईपी म्यूचुअल फंड्स हो गया 3 साल, 5 साल, 7 साल, 10 साल तक रख सकते हैं, सब्जेक्ट टू योर गोल सेटिंग। और लॉन्ग टर्म प्लानिंग के लिए हम लोग बोलते, पहले मैं बोल दिया था कि आपका रिटायरमेंट प्लानिंग हो गया, आपका मैरिज प्लानिंग हो गया, ये सब चीज़ हम सुनते हैं। कोई भी बैंकिंग सेक्टर में जाते हैं, भाई मेरे को रिटायरमेंट प्लानिंग बनाना है, क्योंकि ये रिटायरमेंट प्लानिंग का बहुत बड़ा मेरा स्लाइड है, जब मैं बताऊंगा आपको रिटायरमेंट प्लानिंग किया जाता है एक्चुअली। जो मंथली, जो इमीडिएटली आपको मंथली चाहिए, मैं बता सकता हूँ आपको, जो कि म्यूचुअल फंड सेक्टर में वही है एक्चुअली, जो कि आप रिटायरमेंट विथ प्योरली लिक्विडिटी में रहेगा, मंथली भी ले सकते हैं, एंड एनी टाइम यू कैन विड्रॉ द अमाउंट, कोई भी लॉक इन नहीं रहेगा। तो हम लोग क्या करते हैं कि फिक्स डिपॉजिट देता है हम लोग को, स्लीपी नींद सो सकते हैं, बट हम लोग को जो म्यूचुअल फंड देता है फ्यूचर का प्रोटेक्शन के लिए देता है। क्योंकि म्यूचुअल फंड जो हम लोग का इंडस्ट्री है, 2014 में जितना भी इंडस्ट्री था हम लोग का 1,44 आबादी में, उस टाइम था 10 लाख करोड़ जो इंडस्ट्री अभी इंडस्ट्री धीरे धीरे बढ़ के 80 लाख करोड़ हो चुका है आफ्टर 11 ईयर्स। क्योंकि आप लोग वजह से उस टाइम इतना अवेयरनेस नहीं था, हम लोग इतना म्यूचुअल फंड्स एफडी आरडी हो गया, ऑल्सो आई एम ए बैंकर भी था, तो उस टाइम इतना अवेयरनेस नहीं था। तो ये जो प्रोडक्ट है धीरे धीरे से अभी आप लोगों का अवेयरनेस हो रहा है कि आप थोड़ा बहुत भी आपका एसआईपी कीजिए कि म्यूचुअल फंड कीजिए। और मेरा जो ब्रांचेस है एक्चुअली आपका राउरकेला है, भुवनेश्वर में है, एंड आपका झारसुगुड़ा एंड सुंदरगढ़ में है। तो इसके रिगार्डिंग अवेयरनेस के रिगार्डिंग मैं हर टाइम करता हूँ। मेरा पोर्टफोलियो जितना भी कहीं पर भी क्लाइंट रहेंगे उड़ीसा में पूरा एंटायरली, कि आपका झारखंड हो गया, कहीं पर भी मैं विजिट करता हूँ। कोई भी किसी का डाउट, नॉट टू सेल एनी प्रोडक्ट, टू अवेयर द थिंग्स की एग्जैक्टली म्यूचुअल फंड क्या है। बहुत सारी नेगेटिविटी आता है म्यूचुअल फंड्स के बारे में, तो उसी हिसाब से मैं थोड़ा विजिट भी करता हूँ म्यूचुअल फंड। तो थैंक यू। कोई सवाल है? हाँ बोलिए सर।
बढ़िया है, आपने बहुत बढ़िया समझाया कि धन का इस्तेमाल कैसे करना है, कैसे उसको संभालना है। बट आई वांट टू नो कि आप तो SIP बारे में बता दिए, व्हाट इज द SWP, उसके बारे में थोड़ा बताइए।
सिस्टमेटिक विड्रॉल प्लान वो है, SIP और एक तो STP होता है और SWP होता है। SWP क्या होता है, एक फिक्स अमाउंट आप रख दिए, मान लीजिए 10 लाख 20 लाख रख दिए। जस्ट एग्जांपल आप 30 लाख रखे। आपको गोल सेटिंग करना है कि आपका जो इंटरेस्ट है सिस्टमेटिक विड्रॉल, जो आपका लमसम रखें, कॉस्ट वैल्यू जो रखें, आप उसको मंथली लेंगे कि क्वार्टरली लेंगे कि ईयरली लेंगे कि हाफ ईयरली लेंगे। उसके बाद हम लोग को जो 30 लाख अमाउंट रहेगा, तो हम लोग कौन कौन सा सेक्टर में डालेंगे, कौन का बैंकिंग चल जाएगा, कि आप लोग का आपका फार्मा सेक्टर में जाएगा, कि आपला मैंने आपको जो लार्ज कैप में जाएगा, कि आपको मल्टी एसेट गोल्ड एसेट्स में जाएगा। तो हम लोग उसको डिसाइड करते हैं। उसी टाइम हम लोग को क्लाइंट को बोलते हैं कि सर देखिए मार्केट का जो सिचुएशन अभी है, मान लीजिए हाई पोजीशन में जा रहा है, मान लीजिए कुछ कंपनी होता है कि वो डाउन में जा रहा है, उसी हिसाब से हम SWP क्या होता है कि 3 साल में आपका 30 लाख दिए, हम डिसाइड करते हैं आप 30 लाख में सर आपको 22,000 ले जाए, क्योंकि मार्केट हाई पीक में है, क्योंकि 6-7 महीना मार्केट अभी नहीं चलेगा। तो 20,000 हम क्वार्टर के हिसाब से दे सकते हैं, डिपेंड्स ऑन द मार्केट। वो क्या होता है कि एप्रिसिएशन जो होता है उसी से आप लोग जाते हैं, SWP होता है उसमें।
तो मार्केट, वी आर टॉकिंग अबाउट द मार्केट, तो हम लोग मार्केट में क्यों डायरेक्ट ना इन्वेस्ट करें? मार्केट में हमको 20%, 12%, 24% मिल सकता है, आपके पास तो हमको 7%, 12% मिलेगा ना। कितना दे रहे हैं आप लोग? सपोज
आपका जो है अभी बैंकिंग 10 to 12% हिसाब जाता है। जो रिटर्न है 10.44, मान लीजिए हम लोग किसी भी 30 लाख कर रहे हैं, तो आसपास आप 22,000, 20,000 आप तक आ जाएगा मंथली एप्रिसिएशन के वैल्यू के हिसाब से। बट वो जो इंटरेस्ट है वो डिपेंड करता है मार्केट का कंडीशन क्या है।
हाँ, द मेन थिंग इज मार्केट का कंडीशन।
हाँ,
तो फिर मार्केट का कंडीशन, अगर कारण इज देयर इज अ रीजन फॉर द मार्केट कंडीशन, व्हाई नॉट टू चूज द मार्केट ओनली? आप समझ रहे हैं ना, हम लोग मार्केट को ना चूज करके आपको क्यों चूज करें?
वेरी गुड। आई एम ए फाइनेंशियल एडवाइजर एंड हम आपको लिटरेसी दे, जैसे कि मैं बता दूं आपको कि मेरे को अभी बुखार आया, ठीक है, तो मैंने क्या किया, गूगल में सर्च कर लिया विदाउट लुकिंग एट सिम्टम। तो मैंने कोई भी चीज़ मैंने बुखार है, मैं कोई भी मेडिसिन ले गया, तो क्या होता है कि कोई भी चीज़ मेरे को हो सकता है, साइड इफेक्ट भी हो सकता है। तो हम लोग वो जस्ट लाइक ए फाइनेंशियल डॉक्टर हम लोग बोलते हैं, जो सही गोल सेटिंग करके हम लोग देते हैं क्लाइंट के साथ। बोले कि नहीं मेरे को SWP नहीं चाहिए, मार्केट का कंडीशन है, किरण बोल रहे 6 महीना 7 महीना वैसा है, तो अभी मैं आई एम नॉट गोइंग फॉर SWP, 6-7 महीना तक जा सकता हूँ, 6-7 आई एम वेटिंग फॉर 6-7 मंथ, देन आई कैन स्टार्ट माई SWP सिस्टमेटिक विड्रॉल प्लान। इट विल बी इन अकाउंट्स, जो भी एप्रिसिएशन रहेगा वो धीरे धीरे से बढ़ता जाएगा। उसके बाद मैं सेटिंग करके आपको बोलूँगा कि मेरे को मंथली कितना चाहिए एज पर माई गोल।
गुड, बढ़िया बढ़िया, थैंक यू। और एक रूल ऑफ 72 है, अगर हम लोग मार्केट में जा रहे हैं, वैसे हम लोग जैसे हम लोग फिक्स डिपॉजिट कर रहे हैं, हाँ कि नहीं, 9.5% तो मिल ही रहा है हम लोगों को।
फिक्स डिपॉजिट में अभी का जो
7.5, हाँ
6.5 के साथ
6.5 से 7 साल,
365 डेज,
अगर उसको हम लोग डिवाइड करेंगे 72 से, तो उतना साल लगे हम लोगों को डबल होने में। हाँ कि जी सर, हाँ कि नहीं, हाँ, तो हम लोग क्यों ना करें वो।
Okay, good enough. Theoretically, I could understand there is most difference between doing the FD and your mutual fund. That is there. So my point is, for long-term benefit, definitely mutual fund is the best one, which is giving thrice the amount that we are getting in the FD. Now, whatever the amount we are getting is for the long term. Long term means better 10 or 20 years. My point here is, everything that you are getting at the end of after 10 years, 20 years, it is market link. So if that point of time, if the market doesn't perform very good, then the minimum amount that we will get.
Minimum we will get.
So that will be equivalent to FD also.
Okay, that answer is that like that कि जब में हम लोग गोल सेटिंग कर रहे हैं, we are not going to directly into the market also.
Okay.
हम लोग के पास लिक्विड फंड का एक एसेट रहता है, हम लोग के पास एक रिसोर्स टीम भी रहता है, चाहे वो स्टेट बैंक हो गया, चाहे वो दूसरा कोई एसेट्स रहता है. वो लोग बोलते हैं कि अभी डायरेक्ट में मार्केट में मत जाइए. मार्केट का गोल होता है 6-7 की 5 साल में 3-4 बार की 2 साल तक मार्केट वैसा रहेगा. तो आपको क्या करना है कि जो सर भी SW के बारे में पूछे, उसको बोलते हैं सिस्टमेटिक ट्रांसफर प्लान. ये हम लोग 7-8-9 महीना तक लगाते हैं धीरे धीरे, वो कंपाउंडिंग करके. मैंने डिफरेंट प्राइस 10 लाख दिए तो हम लोग 10 फंड में डालेंगे, क्योंकि आपका गोल सेटिंग 10 लाख है ना, 10 साल है ना. तो धीरे धीरे से करने से क्या होगा, मार्केट मान लीजिए 2 साल में फिर भी नीचे गिराया तो उसके बाद कभी भी मार्केट बढ़ेगा. क्योंकि 1979 में हम लोग का मार्केट का वैल्यू 100 रुपया था.
ठीक है.
अभी मार्केट का वैल्यू जो मार्केट का 85,000 है, निफ्टी 26,000 में ऑलरेडी टच कर चुका है. तो कभी भी आप 10 साल में मार्केट ऊपर तक जाएगा मिनिमम, जो FD से तो थोड़ा ज़्यादा आपको मिलेगा.
That means what I guess from your word, you have that contingency plan. Actually, you are not putting directly money into the market. You have that contingency plan. In that contingency plan, you have that idea that when to put the money into the market. Okay. That means we are assured that definitely the interest that we will get definitely will be double or more than or 15 to 30% what you are taking. That point is well taken. Now we are keeping it for long term. Now I am talking about the platform where we will invest. As of now, what we are doing, we are going through the mobile, I mean through app like Angel One or Zerodha or whatever this. So we are putting that amount there. I mean everything is doing through the online. After 20 years, suppose that platform is gone from this world, then where to contact, whom to contact?
Nice question actually. Zerodha and Angel One, these are the exchange. These are the exchange, the stock broking company. Earlier we had a Carby and आपका जो Motilal Oswal and Motilal is there also. India Infoline, Carby and India Infoline. Now there is no Carby and India Infoline. तो क्या हुआ कि उस टाइम जितना डीमेट होल्डर थे, जो डीमेट अकाउंट होल्डर थे, उनको चेंज कोई दूसरे ने टेक ओवर किया है. बट हम लोग जो मिडिल क्लास फैमिली रहता है, इतना नॉलेज हम लोग जिस साइड में करते हैं, तो हम लोग को दिक्कत होता है उसको वहाँ पर शिफ्ट करने के लिए. तो आई एम गिविंग यू द बेटर एडवाइस टू इन्वेस्ट योर अमाउंट, इन्वेस्ट योर मनी थ्रू डीमेट इन स्टेट बैंक ऑफ इंडिया. तो स्टेट बैंक ऑफ इंडिया इज द लार्जेस्ट एसेट कंट्री. वो SBI सिक्योरिटी सबसे अच्छा है. कोई बैंकिंग खुद का एसेट है जो लॉन्ग टर्म के लिए रहेगा, फ्यूचर के लॉन्ग टर्म के लिए. जैसे बैंकिंग का रिवोल्यूशन हो रहा है, धीरे धीरे क्या हो रहा है, धीरे मर्ज हो रहा है और बैंकिंग मर्ज होगा. इतना बैंक खुला है PSU में, अभी तो बैंक मर्ज कर रहा है, इतना कितना करेगा, लॉस हो रहा है ना. तो धीरे धीरे क्या होगा, आप जो भी चूज करेंगे, तो स्टेट बैंक हो गया, HDFC सिक्योरिटी हो गया, एक्सिस सिक्योरिटी हो गया, दीज आर द प्लेटफॉर्म टू इन्वेस्ट योर मनी इन शेयर्स एंड बॉन्ड्स ऑल्सो.
Okay, the point is all taken. We have to go through the SBI related here. Okay, that's
secure also.
Okay, that is fine. Now suppose for tomorrow, I am going along with you. Siddhi Enterprises. ठीक है. The mode of payment or process, what you will do? You will club with some other or independently you have that
I'm a
system
consult. We are the consultant
Only
actually.
consultant.
Only
Okay.
consultant. You have to give the check in the name of anything. SBI mutual fund, Axis mutual fund, anyone. Not to about me also.
Okay.
I am only advisor to advise you, guide you also.
Okay, understood.
Not to give you.
You are the consultant. You will facilitate. You are a facilitator. Okay, thank you.
दादा नासेना जिनसलिंग एडा सॉरी दादा 1 मिनट 2 मिनट लिया नासेना जिनसलिंग एडा जो तो बखरा गे फाइनेंशियल लिटरेसी दो डी इम्पोर्टेंट जिनस का गया मिटांग 6 मास को सलिंग छोटो मोटो लिंग करावा का ना जिसलिंग मेन दाड़े अब जुदे बनेल कान जो तीन बो तकिन जाकिन कुलिकेट बना नी तेहन खन 20 वर्ष पछले बखान 10 वर्ष पछले बो नेल अब दिसम चे लेका ताहे कना ओड़ा दुआर चेक लेका ताहे कना तीना गाड़ी घोड़ा बो यूज ताहे दो 10 वर्ष मांग रे बखान 20 वर्ष मांग रे और नितो ओना जिनस बो नेला अबो अतु रे चेक लेका को ओड़ा का चेक लेका गाड़ी घोड़ा को यूज 10 वर्ष मांग रे साइकिल के ताहे कना हॉर ठीक से बाय ताहे कना और नुआ फोन फोन चेन बाय ता नितो जो हाथ रे फोन मेना चेक लेका तो होइना किछि कंपनी ओडे पैसा को लगावा का ओना खातिर नोआ दो नोका हुई करा सरकार इया का किंतु सरकार निजे तो पैसा बाय लगावा का किछि कंपनी को लगावा का तो अब जहाँ बो बतौर जे पैसा पाचे मार्केटिंग डालाव खान कमोआ ओना दो तब बाय कमोआ चेदा बाय कमोआ नुकु कंपनी दो चेतान सेट को राकाब कना को लातार तो बाको आणगोना नितो जहाँ स्टैंडर्ड रे मेना बना अब नोडे खन 20 वर्ष पछले लेका स्टैंडर्ड बाबो चलाव दरे अब 20 वर्ष मांग जहाँ ओड़ा दो ताहे कना जहाँ लेका साइकिल बो लगाए था उनका तो बाबो ही रोड दरे मार्केट न्यूरो रहो उना लातार तो बाय चला चेतान रेगे ताहेना तेणु ओना खातिर म्यूचुअल फंड दो वन टाइप सेफ गया जहाँ दिन रिटर्न अब 15% के 12% बो एक्सपेक्ट है उना बाय हेज दड़े किंतु फिक्स डिपॉजिट खन दो ढेर गे तब हजुआ और मिटान कथा जो अब पैसा नुई इदिया नुई तो रायबारिज कना तब नुई पाचे पैसा इदी कते उठाव बो मेने नुई तो इदी कते तो बाय उठाव दड़े चे लेकाते बाय उठाव दड़े नुको दो सेबी मेनते मिटान ऑर्गेनाइजेशन मेनाया सिक्योरिटी एक्सचेंज बोर्ड ऑफ इंडिया उनी अंडर रे कंट्रोल रे मेना को जहाँ को जिरोदा फिरोदा मेन कर को एनखान तो उनी सेबी अब सेव कते दो बाने ओनाते अब टाका दो बुडा रे चांस दो बना किंतु जहाँ बॉन्ड बो नामिया बखान जहाँ नंबर बो नामिया ओना अब सेव कते दोते हुई बना अब पेपर करे बो आंजमिया जे ओकय हर तो 1000 टाका दो हले ताहे दो उनी होड़े गोचेन गया 20 वर्ष होन गया आज नाते पोती ओना को नाम के सर्टिफिकेट और नितो करोड़पति उनको दो ओना तो ओना खातिर हुआ कागज जो ताहे को कना कागज तम एनखान दो ओना पैसा दो तम हारा गया इनाली मेने गानो गानो
अड़ी
तो जस्ट रायबारिज कना
अड़ी एकदम सही कथा डॉक्टर मुर्मू व्हाट यू आर टोल्ड इज वेरी राइटली and also we are also personally I feel I am also very much benefited out of him because what earlier we are doing is we are just putting it into the saving accounts or in the fixed deposit, but after getting in touch with the Siddhi Financial or personally with the Kiran Kumar, what he educated us about the SIP and SWP, and he has advising for us and putting our like financial resources into that, and we find it, yes, it is a healthier institution and it can grow, and hope that everyone should come forward. I think in the earlier age, those who are just an early service or early earlier in job, they can certainly do some kind of SIP so that they can their money will grow, and by the time when they are coming into the age of 40, they are certainly they will be very much financially sound. Ado na saw mena nukindo abo noa conference re do adi tekin golo mena pale nukina golo tege tabo danda ko ketek katet non marang noa jaha auditorium ko do hataw dare नोआ लगी दो अड़ी सरहाव और डॉक्टर मुर्मू सर तकिन लिंग नेहर किना अकिन नुकिन करण सर तकिन किन फेलिसिटेट किना ये करण सर करण
फोटो उठा दो ना अच्छा मोबाइल
ओके थैंक यू सर पालन रेंगेज इदी बना नितो दो तो लंच सेट बन चला और 45 मिनट्स पूरे बन नापा मार दोड़ा गिद्रा को सेशन हाँ बाय चावा कान गया साइंटिफिक सेशन ᱦᱳᱭ ᱚᱱᱟ ᱱᱤᱛᱚᱜ 2:30 ᱦᱩᱭᱩᱜ ᱠᱟᱱᱟ ᱛᱚ 3:15 ᱨᱮᱵᱚᱱ ᱧᱟᱯᱟᱢᱟ ᱟᱨ ᱫᱚᱲᱦᱟ ᱱᱚᱰᱮ. And I would like to request our judges to be please present for the session. 45 minutes pore tobe node bon hijua. And all the students are requested to be present. Those who have not presented yet, please be present.